Good
live.
evening to Sahiti, recording is started.
Yes, ma'am.
Yes, good evening to all. I welcome you all for the TNFOG Marathon CME. This is the CME which is conducted on second Friday of every month. Here we have 3 sessions. First session for being the UAS. For this UAS, 2 talks will be given and it will be judged by the same judges on all CMEs. At the end of the year, in the TNFOG annual conference, best speaker will be awarded. And at the end of the session, we will present questions to the delegates. And the second session being the research advance by seniors. And third session being the panel. Today we have the theme as awareness of O and B. What is this O and B? That is ovarian cancer and breast cancer. This week is the awareness week of ovarian cancer. So we had the theme as O and B awareness. I welcome you all again. And today's MOC is Dr. Radhika. I hand over the mic to Dr. Radhika. I welcome my teacher, Dr. Shantamani Madam, for accepting to be as the chief guest. Thank you, ma'am. Radhika, you can take over.
Okay. Good evening, all respected Revati Madam, Sampath Madam, and Shantamani Madam is our teacher. And good evening, all esteemed chief guests and delegates. We are going to have an interesting session today. Let us start with lamp lighting.
Tamil Thai Varthu.
Tamil Thai Varthu.
Yes, Sahit.
So next is the welcome address.
Mute learning.
Radhika, you invited Revati Madam for the welcome address and introduce chief guest.
Sure. Ma'am, may I invite Professor Dr. Revati Ma'am to kindly give the welcome address, please. Professor Dr. Revati Janakiram Ma'am is a former director of IOG Chennai, and she is the Vice President FOGC South Zone 2016 and President of TNFOG 2023. She has been the Founder Secretary and past President Madurai OG Society, Founder President IMS Madurai Menopause Society, President Madurai Chapter of Tapisar, recipient of FOGC Dr. Durusha Community Services Award, recipient of Lifetime Achievement Award IMA Madurai. She has been selected as Master Trainer for PPIUCD program by FIGO FOGC. Author of FOGC Focus on Amniotic Fluid A to Z, contributed many chapters in FOGC Focus issues, and contributed chapters in many UG and PG books. Pride of Foxy Award in November 2019 at Mumbai. May I invite Madam to introduce and welcome Shantamani Madam. Thank you.
Thank you, Radhika, for the nice introduction. It's my great pleasure to welcome you all to this very, very important CME. And as Dr. Sampath was telling, May 8th is Ovarian Cancer Awareness Day, Global Awareness Day. And clubbed with the breast cancer, we are having this ONB CME today. And it's my great pleasure to welcome our chief guest, Dr. Shantamani Madam, who is my daughter's teacher and close friend of mine. And she was retired professor obstetrics and gynecology, it is IOG, life member of Oxy. She has teaching experience of more than 35 years. And I heard that she is the teacher of all the participants here. And she was also examiner for UGs and PGs. And also I welcome all the judges, the permanent judges, Dr. Nidhi Sharma, Dr. Vijayalakshmi Kandasamy, Dr. Inba and Suganya, the Yuva speakers, and all the faculties, Dr. Malliga, Chandrapannaswamy, Deepthi, and Dr. Shanti Gunasingh, and all the panelists. And also I welcome all the delegates who are definitely going to be benefited by attending this, because you are going to gain a lot of practical points from this CME. And I request Shantamani Madam to say a few words. Please unmute and say a few words, Madam, and bless us. Shantamani Madam, unmute.
Okay. Priya?
Yes, yes,
Priya.
yes, Madam. Madam, you are heard. You are heard. You can start, Madam.
Good evening. I am extremely thankful to the
TNFOG.
Organizers. Extremely thankful to the organizers of Tamil Nadu Federation of Obstetrician and Gynecologists for being invited me as a guest for this program. I'm extremely happy, and I'm thanking Dr. Revati and Sampath Kumari, the organizers. I'm very happy to know that monthly CMEs are conducted every second Friday, routinely with a particular theme. Today's theme is breast CA and ovarian CA. It is interesting to note that the junior Yuvas are talking on the basics of the subject, and the senior professors are talking about the advance and recent advances, so that the audience can have the complete knowledge about the meeting, about the subject. And Yuvas are also encouraged by prizes given by the judges from senior professors. And appreciate the organizers that in spite of your busy schedule, you have been conducting the CMEs successfully for the past 2 to 3 years. I really appreciate it. And you are conducting monthly classes for postgraduates also. Regarding the subject, cancer breast, you all know this is the commonest cause of death in women in our country. The main reason is it's very difficult there are no screening methods to detect the pre-cancerous conditions like CA cervix, like we have in CA cervix. Apart from breast examination, that is self-examination, I would suggest that every woman who comes to the hospital, either it is for gynec OP or medical, surgical or pediatric woman, pediatric OP, every woman should be subjected for complete breast examination by a trained personnel to find out the early lesions. Regarding the CA ovary, you know, the peculiarity of anatomical peculiarity of the ovary, it is the only intra-abdominal organ which is extra-peritoneal. It is not covered by peritoneum. What is the significance? God has created everything with the significance, because for ovulation and ovum pickup. Whereas the disadvantage is it can grow freely into the abdominal cavity under the perinephric region, and as you know, the mammoth tumors of the abdomen have been reported only from the ovary. The patient doesn't have any pain because there is no peritoneal covering, no stretching, no pain. Only thing in mammoth tumor, she will have pressure symptoms. And coming to ovarian cancer, it is very unfortunate that we can diagnose ovarian tumors only in 3rd stage. The patient comes to the doctor when the lesion spreads to the adjacent structures and she has pain and she comes to the doctor. With this introduction, I invite all the speakers to start the CME. I once again thank the organizers for involving me in this very useful program. Thank you.
Madam, release the newsletter also, Madam. Sahiti.
Yes, ma'am.
Sir.
Yes, thank you, ma'am.
Radhika can take over.
Shantamani, ma'am, we release the e-newsletter of the theme every month.
Okay. What is that? Newsletter, madam.
Newsletter. இப்ப ரிலீஸ் பண்ணாங்க இல்லையா மேடம்? அதுதான். உங்களுக்கு ஒரு காப்பி அனுப்ப சொல்றோம் மெயில்ல.
சரி.
நீங்க பாருங்க உங்களுக்கு வரும் கட்டாயமா.
I'm going to involve myself sincerely with this federation.
Thank you. Thank you. Radhika, unmute.
Thank you, ma'am. The first session is the Yuva session. So the judges are Dr. Nidhi Sharma, Professor Savita Medical College. She has done her MBBS and MS from Banaras Hindu University, Varanasi, India. She's a fellow of Indian College of Obs and Gynae, also a fellow of Assisted Reproductive Techniques. She has a diploma in IVF and reproductive medicine from UK.
Thank you, ma'am. Thank you so much, ma'am.
And she's received numerous awards and journals also. And Dr. Vijayalakshmi, ma'am, is a professor at Chettinad Hospital and Research Institute, Kelambakam, Chennai. She has received special prizes and achievements. She's a State Secretary Appreciation Award for exemplary performance in IMA activities in 2021. She's held
Thank you, Radhika, madam. Thank you so much.
Thank you, ma'am.
We are constant presence here. Thank you so much for
Thank you, ma'am.
introduction. We will go on.
Okay. So the first session is counseling and screening of cancer breast by Dr. Inba Priyanka. She is a graduate from 2008 batch and a postgraduate in 2015 MMC batch. She's finished a Dipend OG and also MRC OG in 2022, and she's working as assistant professor in Kanyakumari Medical College. So can you please start the session?
இது ரிமூவ் பண்ணிட்டீங்கன்னா நீங்க பேசலாம்.
So we'd like to invite Dr. Inba Priyanka, who is going to be talking on counseling and screening of breast cancer.
Yes,
Dr. Priyanka, you may start your presentation. And we would like to inform both the speakers that you have a time limit of 12 minutes. Okay. And we will have 3 minutes for discussion.
Okay, sure, ma'am. So good afternoon, ma'am. Ma'am, am I audible?
Yes, you're audible.
Okay.
Audible.
Okay, ma'am. So my topic today is counseling and screening of breast cancer. So why do we need breast cancer screening? So because the carcinoma of breast is the commonest cancer of women worldwide. And also the incidence of breast cancer is on the rise in India. Early detection of breast cancer through screening, it is the only means to reduce the burden of morbidity and mortality. So screening is done to detect preclinical disease in healthy asymptomatic women to prevent adverse outcomes, improve survival, avoid the need for more intensive treatments. So coming to the benefits of screening, so the benefits are improved health outcomes. but it has certain adverse consequences as well. So they are increased cost, anxiety to the patient, inconvenience to the patient, false positive results, overdiagnosis, and overtreatment. So initially, when a patient comes, we have to assess every woman about the risk factors of CA breast. So the ACOG recommends healthcare providers to periodically assess breast cancer risk by reviewing the patient's history. And when a patient with a history of increased risk of breast cancer, then they are subjected to further risk assessment. So these are the risk factors that you have to ask in history. So like family history of breast cancer and other cancers and other hereditary cancers, known gene mutation, prior breast biopsy with specific pathology like atypical hyperplasia and lobular carcinoma in situ, early menarche, late menopause, nulliparity, prolonged interval between menarche and first pregnancy, menopausal hormone therapy with estrogen and progesterone, and if the woman is not breastfeeding, increasing age, certain ethnicities, high BMI, alcohol and smoking consumption, dense breast on mammography, and prior exposure to high-dose therapeutic chest radiation. So these are the risk factors which you have to ask the patient. So, and if the patient is at a high risk of breast cancer, then they are subjected to further risk assessment by these models. So these are few models which are used, and the most commonly used model is the Gale model. And depending upon the risk scoring, the women are designated as low risk, average risk, and high risk. So this is a new topic which all the guidelines have recommended, which is a shared decision making. So it is nothing but a process in which the patients and physician share information, express treatment preferences, and agree on a treatment plan. So it combines the expertise of the physician who provides the details such as benefits of the procedure and as well as harms of the procedure, and the values of the patient who shares her experiences, concerns, and priorities. So the ways of providing clinical information include online videos or reliable web pages, informational handouts, and face-to-face conversation. So coming to the screening methods. So they are physical examination includes breast self-examination, breast self-awareness, clinical breast examination, then mammography, ultrasound, and MRI. So coming to breast self-examination. So now the guidelines say that it is not recommended in average risk women because of the risk of harm from false positive results and also lack of evidence of benefit. So there is a new term called breast self-awareness. So it is nothing but a woman's awareness of the normal appearance and feel of her breast. So it does not include examining her breast in a systematic way like the breast self-examination. But women should be attuned to notice changes or potential problem with her breast. And they should be educated about the signs and symptoms of breast cancer. And they should notify the healthcare provider if they notice any change. So the US Preventive Services Task Force, it supports all patients being aware of changes in their bodies and discussing these changes with the clinicians. Even American Cancer Society says that clinicians should counsel women regarding the importance of being alert to breast changes. So then comes the clinical breast examination. So the patient should be undressed to the waist and seated with arms by the side. And we have to note the size of the breast, symmetry, shape, color, lumps, and skin tethering, and whether the nipples are everted, flat, or inverted, or whether any cross deviation, bleeding, or discharge. And we should also observe the areola for abnormal reddening and thickening. So for average risk women, the guidelines say that we should have an informed shared decision making regarding clinical breast examination. If the patient agrees, if the woman agrees to do a clinical breast examination, then the ACOG and National Comprehensive Cancer Network says that it can be offered every 1 to 3 years for women aged 25 to 39 years and annually for women 40 years and older. But US Preventive Services Task Force and American Cancer Society does not recommend clinical breast examination, but it is recommended for high-risk women. Next, coming to screening mammography. So it is an X-ray of the breast and it is reported as a BIRATS scoring. So we have 0 to 6 score. So here each breast is compressed horizontally between two plates for imaging and also diagonally. So mammographic manifestation of breast cancer. So you can find ill-defined mass or speculated margins, and there can be architectural distortion of the breast. The tumor may be hidden by dense parenchyma. Even calcifications can be associated with either benign or malignant conditions. And also the tumors will be 100 to 300 micrometer in size and are rod-like, tubular, branching or punctate. Clusters of microcalcification are suggestive of intraductal disease. So these are the findings of a breast cancer in mammography. So coming to the studies. So based upon the various trials and studies, for women aged 40 to 49, they say the mammography, doing mammography may save lives, but the benefit for younger women is less than compared to older women, and the evidence is not definitive. And it says that there is a 15% reduction in mortality from breast cancer for annual screening of women aged 40 to 49. However, the risk reduction is less than that for women aged 50 to 69 years, and there is a high chance of false positive and false negative results. So for women aged 50 to 69 years, the life-saving benefits of mammography are clear. So all women aged 50 to 69 years should have a mammogram on a regular basis, because trials have shown reduction in breast cancer mortality up to 25% in women aged 50 to 69 years. So for women above the age of 70 years, so overall, the screening mammography is beneficial for women aged over 70 years who are in good health and have a life expectancy of about 10 years. However, data is not available to identify an upper age limit at which the screening mammography ceases to be appropriate, and the decision should be made by patients in consultation with their healthcare providers. So as you know, advantages of mammography include shift to earlier stage, decrease in mortality, and early detection. But there are also adverse consequences like false negative result, anxiety and distress to the women, discomfort during procedure, and overdiagnosis. So it is a term which states that the cancer detected through this mammography that would not have progressed to symptomatic cancer if left undetected. And another term called over-treatment, which is the initiation of treatment for this overdiagnosed cancer. And there is also a risk of radiation exposure. So next comes the digital mammography. This is transforms X-ray images into electronic digital images. So advantage is no film processing and faster image acquisition and less callbacks. But the sensitivity is similar to that of screen film techniques. The next method is the ultrasound screening. So it has a role in high-risk population and young women with mammographically dense breasts. So it has a sensitivity of 73% and specificity of 95%, but has disadvantages of high false positive rates, operator dependency, inability to image ductal carcinoma in situ. Then comes MRI screening. So MRI screening is also indicated for high-risk women and single screening of the contralateral breast. So it has a high sensitivity of 70 to 100% and specificity of 80 to 99.9%. So it has a disadvantage of recall rates and biopsy rates 2 to 3 times higher than mammography, and it is also very expensive. So thus it is limited to high-risk patients only. So annual MRI recommendation based on evidences for BRCA mutation, untested first degree relative or BRCA carrier, and a lifetime risk of breast cancer 20 to 25%. An annual MRA based on expert opinion is radiation to chest between age 10 and 30, Lee-Fromeny syndrome, and first degree relatives. Others are insufficient evidence. So the ACS, American Cancer Society guidelines, recommend screening MRI as a supplement to early mammography beginning at age 30 for women who have a high lifetime risk. So there are also newer tests from breast imaging, like molecular breast imaging, photon emission mammography, contrast enhanced mammography, optical imaging test, electrical impedance imaging, and elastography. However, additional trials are needed for the use in screening of breast cancer. So coming to the guidelines regarding screening of average risk women. So the American Cancer Society says that for 20 to 39, as we've already seen, the clinical breast examination should be done, if the patient agrees, should be done every 1 to 3 years. And from 40 years, it says the patient should have the opportunity to begin annual screening from 40 to 54 years. And above 55 years, it recommends the women should transition to biennial screening and or have the opportunity to continue screening annually. So this is a comparison of the recommendations for breast cancer by various societies. So as we have already seen, the American College ACOG and National Comprehensive Cancer Network recommends clinical breast examination may be offered every 1 to 3 years for women of age 25 to 39 and annually for 40 years. The US Preventive Services Task Force and American Cancer Society does not recommend. And for mammography, ACOG offers starting at age of 40 years. ACOG and National Comprehensive Cancer Network recommends starting the age at 40 years. However, US Preventive Services Task Force recommends the age at 50 years, and American Cancer Society also offers at 40 years, but recommends at 45 years. So the mammography screening interval is annual or biennial, depending upon the age. So when will you stop this? The ACOG recommends to continue until age 75 years. So beyond age 75 years, there should be a shared decision-making processes. And American Cancer Society says when life expectancy is less than 10 years, you have to stop mammography. And when severe comorbidities limit life expectancy to 10 years, also you have to stop mammography. So coming to screening of high-risk women, so there are 3 components. You have genetic screening, breast screening, and cancer prevention. So as you all know, so the genetic screening involves especially P53, BRCA1, and BRCA2. So the increased risk of breast cancer is with family history. With single first degree is 1.7 to 2.5 risk. Higher risk, multiple first degree relatives is 4 to 6, and second degree relative is 1.5. So the EMPRACE study shows that the risk of breast cancer for a woman with BRCA1 is 60%, and with BRCA2, it is 55%. Contralateral is from BRCA1 is 83, and BRCA2 is 62%. So these are the indications for genetic testing. So the women with a family history of known BRCA1 and 2 mutation and a personal history of breast cancer, plus with age 45 years or younger, age less than or equal to 50 years, with 1 or more close relatives with breast or prostate or pancreatic cancer, age less than or equal to 60 years with triple negative breast cancer, any age with 2 or more close blood relative with breast, pancreatic, or prostate cancer. So more than or equal to 1 close blood relative with breast cancer, more than or equal to 1 close relative with ovarian cancer, and a personal history of epithelial ovarian, fallopian tube, or primary peritoneal cancer, and personal history of male breast cancer. So this is the current screening guidelines for high-risk women. So just remember, the National Cancer Comprehensive Network recommends that women at high risk should get a mammogram and breast MRI every year, starting at the age of 25 to 40, depending upon the type of gene mutation. And women at high risk should also
Dr.
have.
Inba, your time is up, ma.
Yeah, ma'am, I'm going to complete. Yeah, it's over, ma'am. Have clinical breast exams every 6 to 12 months, beginning at the age of 25. And the American Cancer Society says that the women at high risk should get a mammogram and breast MRI every year, starting at the age of 30 years. So this is the recommended screening algorithm. So women who are diagnosed with lobular carcinoma in situ and atypical ductal hyperplasia and atypical lobular hyperplasia. So mammography has to be done annual after diagnosis. With a personal history of breast cancer, also mammography has to be done annual after diagnosis. But with a family history, you have to start annual, starting 10 years younger than the youngest relative, but not younger than 25 years of age. And with Hodgkin's lymphoma treated with mantle radiation, the annual mammogram starting 8 years after the treatment. And once the screening has been done, then if the woman is at high risk, she can undergo more frequent additional intensive screening modalities such as breast MRI or risk-reducing surgery such as mastectomy or salpingo-oophorectomy and medications such as tamoxifen. So the breast screening has a significant impact on mortality and prognosis of breast cancer. So with breast screening, the cancers can be detected early, and also breast surgery such as breast conservation is possible, as well as it causes reduction in mortality. So in our country, breast screening should be given due importance, and the primary healthcare providers should make the general population aware about breast screening and its protocol. Thank you.
That was a nice presentation. Can I ask one question? See, can you tell what is Birad's grading?
Ma'am?
Birad's grading. Birad's grading.
Yeah, ma'am. Birad's grading is done by mammography. So it has 6 grading, 0 to 6. So 0 is, I think we have to repeat the mammography again. 1 is negative, 2 is benign, and I think it moves on to 6 means it is it says that the patient has a cancer of CA breast.
Okay. And suppose any age limit, you know, like after this, before this, I'll do an ultrasound for screening, and after this, I will do a mammogram for screening. Any cutoff age?
Ma'am, actually, trials, it has not shown ultrasound to be effective for younger age group women, ma'am. That too for screening of average risk women. So it is ultrasound is beneficial only for high risk women. And I think like maybe after 45 years of age, because in younger women, because of the increased density of the breast.
What will you do if the breast is dense? Ultrasound or mammogram?
No, if the breast is dense, then we have to do an ultrasound, ma'am.
Okay, so younger women, we should do ultrasound.
Ultrasound.
And after 35 years, we can do with mammogram.
Mammogram.
Thank you.
Dr. Inba, are you aware of any other modalities of screening that are available apart from the standard mammogram and ultrasound? Are you aware of any kind of artificial intelligence based screening modalities that are available?
No, ma'am.
Yeah.
Is there any?
We have one what is known as thermalytics, wherein it is based on thermal screening, thermal imaging of the breast, which then the AI interprets to give the report. So when you are talking about screening, it's also worthwhile to look at the various other newer modalities that are coming up, which in fact can be applied to younger women. And also it does away with this problem of, you know, very dense breasts, especially when we do this thermal breast imaging.
Okay.
Yeah. It was a nice presentation, Dr. Inba.
Thank you. Thank you.
Thank you.
So now we are moving on to the next speaker. Is it Dr. Suganya, Assistant Professor from Coimbatore Medical College, who has graduated from Madras Medical College, both her MBBS and MSOG. Over to Dr. Suganya for her talk on screening of ovarian cancers. Dr. Suganya, are you there?
Yeah, yes, ma'am. Yes, ma'am. I'm trying to open my slides, ma'am.
Sahiti, please help her out with the
Okay, ma'am.
slide share.
Suganya, ma'am.
Yes, ma'am.
Ma'am, please click on share screen green color option, ma'am, so that slides will be shared.
Share screen. Yes, ma'am. I click the share option.
Okay.
Share screen.
You're sharing from mobile,
Yes,
ma'am?
ma'am.
Or laptop?
Yes, ma'am. Mobile, ma'am. It's in my
Okay.
file manager. My PowerPoint is.
Please open the PPT first and then you click on share screen option, ma'am, so that slide will be shared.
Okay, ma'am. Yes, ma'am. I open my PPT. Then what to do? Projection.
Or should she log out and log in back again, Sahiti? Maybe she's not able to share screen.
Suganya.
You have to share from laptop at least, ma. Not from mobile. You find it very difficult.
Okay, ma'am.
Yeah.
Maybe
At
she
least,
can
Join through laptop, ma'am.
yeah, that is important, Amma.
Hello.
Yeah, you
Am I
can
audible,
join
ma'am?
through laptop, Suganya, you'll be able to join.
Open out, ma'am.
she can forward it.
Hello, ma'am.
Dr. Suganya. Dr. Suganya.
Yes, ma'am. Yes, ma'am. Am I audible, ma'am?
Yes,
You're audible, ma'am, but your slides,
Start
it's not
screen.
shared. Ma'am,
Yes,
if
ma'am, I'm
possible,
trying to
please send
open,
it to my mail ID, ma'am. I will
I'm
share
opening
it
in my
on-
laptop. Okay. Start screen early.
Or you can send it to Sahiti. They can share.
Ma'am, your mail ID, please, ma'am.
I have sent in chat box, ma'am. Please check.
Sahiti,
Yes, ma'am.
I think in future it's better that you get the presentation from both the UR speakers
Yes, ma'am.
and
That's
have
good.
it as a backup. Okay. So we're experiencing a lot of delay as a result of this, isn't it?
Share screen.
சாகிதி அனுப்பிச்சிட்டாளா
Yes, ma'am.
இல்லையா?
No, ma'am, not yet, ma'am.
ஆமா, விஜய் மேடம் சொன்னாப்பல இனிமே முதலே வாங்கிக்கணும்.
Ma'am, I have uploaded the poll question, ma'am. Shall I launch the question, ma'am?
சரி, அந்த இத கொஸ்டினை போட்டுரு சாகிதி.
Okay.
டெலிகேட்ஸ். ராதிகா அதை அனௌன்ஸ் பண்ணிடு.
This is the first question. High-risk women should start mammography from 16 years, 20 years, 30 years, 40 years. Delegates?
Panelists cannot participate in the poll.
This is only for delegates.
Last 10 seconds.
Yes.
Time up.
Yes, thank you. At the end of the panel, second question will be posted.
Suganya ma'am, have you sent the mail, ma'am?
சுகன்யா அனுப்பலன்னா அடுத்த டாக் முடிச்சுட்டு அவளை பேச சொல்லலாமா?
ஜட்ஜஸ் வேற ஏதாவது வேலை இருக்குமே மேடம், அவங்க பாவம் மாசம் மாசம் வராங்களே.
அவங்களோட இதை வச்சுதான்.
சுகன்யா, சுகன்யா எந்த சொசைட்டி?
கோயம்புத்தூர் மெடிக்கல் காலேஜ்னா
கோயம்புத்தூர். எஸ், மனோன்மணி மேடம் சொன்னாங்க, கரெக்ட். சாந்தி மேடம், வெல்கம். Nidhi Sharma, Vijayalakshmi Kandasamy madam, is it okay after the second talk if Sukanya is
yes
giving
madam,
a
I think we're wasting a lot of air.
Can save time. Yeah.
Okay ma'am.
Radhika, you proceed next to the question.
Deepthi madam introduce panna Radhika.
Yes ma'am.
You introduce the chairperson.
Yes ma'am. I introduced may I invite Dr. Mrs. M. Malliga madam, who's the director of Thangam Hospital and Thangam Care Center. She is the first obstetrician to handle HIV positive antenatal mothers in the early 1990. She's delivered more than 250 babies for HIV positive mothers. She is the past president of Inner Wheel Club of Namakkal, and Best Club Award was given to her during that period. And she is the vice president, IMA Namakkal, treasurer Namakkal Women's Doctors Association. She's been the past president, IMA Namakkal, for 2 years and got awards for best president, best club in all activities. She's the chairperson, IMA TSP Women Empowerment Committee. So I invite Dr. Mrs. Chandra Ponnusamy, MBBS DGO, FIC OG DRM. She's an obstetrician, gynecologist, IVF specialist consultant, Chandra Nursing Home and Fertility Center, Namakkal, UG and PG in Government Stanley Medical College, Chennai. She's been awarded gold medalist for proficiency in anatomy, ophthalmology, pediatrics, ONG, and she started the first laparoscopic and IVF center of her district, Namakkal. And she's affiliated to FOGSI Association since 1982. She's life member of IMA, ISAR, Images, IAG, PCOS Society, founder president of Namakkal OG Society, EC member of TNFOG. She's a faculty in many national conferences, and she's been awarded many awards. And I invite both madams to start this session. With Dr. Deepthi Mishra, who's a consultant surgical oncologist, Thangam Care Center, Namakkal.
Radhika, chairperson, will introduce Deepthi.
Yes, ma'am. Yes, ma'am. May I invite the chairpersons to please introduce Dr. Deepthi, madam.
Good evening. Malliga. I will talk. You introduce. Great pleasure in introducing the next speaker, Dr. Deepthi Mishra, surgical oncologist from Thangam Hospital, Namakkal. She finished her MBBS in Government Medical College, Berhampur, Odisha, and MS General Surgery, KGMU, Lucknow, UP, and MCH, Surgical Oncology, Tata Memorial Hospital, Bombay. Her special interest was in robotic and laparoscopic pelvic surgeries and complex surgical oncology, peritoneal surface malignancy, and breast cancer. India ranks third worldwide behind China and the USA in the total number of cancer cases as per the results of the National Cancer Registry. The estimated cancer incidence in India in 2022 was 14,61,427. That is 100.4% per in 1 lakh. This incidence is projected to rapidly increase by 2025. In India, the probability if a person to develop cancer in his, her, or her lifetime is 1 in 9. There is a greater number of female cases. Among them, breast cancer is the most common, followed by cancer cervix and ovarian cancer. Even with so many awareness programs and information over social media, we still see advanced cases. People tend to skip the screening opportunities and sometimes delay consultation for various reasons, fear, social stigma, and chance of extensive surgeries and chemo and radiotherapy side effects. But as in all other fields, oncology has grown in leaps and bounds. There are new diagnostic, therapeutic, and palliative measures, and I'm sure Dr. Deepti has a lot of information to share. I invite Dr. Deepti to address about breast cancer and ovarian cancer. What is new? Dr. Deepti?
Yes. Thank you, ma'am. Thank you, Tamil Nadu Foxy, that I really appreciate this, that you have given me this opportunity, and I was just listening to the last lecture, and it was really that when the presenter and the what was the interaction, it was very high quality. So the thing is, today, but what I am going to present whenever we make something, because there is a difference in the each specialty. Today, if somebody asks me about the obs and gynecology, probably my knowledge is very less now. So being an oncologist, I wanted to focus on the things which are very important. Nobody should miss it, whatever is your specialty. So I have not included any references. I did not make it very highly theoretical. I made it practical. So I think so it will be very useful for everybody. And my sincere thanks to Sampath Kumari madam, that she always remembers me to just share something, whatever is there. And with that, I would like to start my presentation. Madam, can I?
Welcome, Dr. Deepti.
Yeah. So there are hundreds of things each day there are coming, because we know that, as Dr. Mallika madam has told, that the breast cancer is the #1 cancer in Indian women also. So the thing is, the scenario from the beginning of this cancer to now has changed a lot, because earlier the modalities of diagnostic modalities, treatment facilities, all were not that good. In 10 years, it has just crossed that line, and now you see more and more ladies are getting cured by the cancer. At least, if not getting cured, they are living with a good quality of life, even with the disease. It means in the stage 4 also, we are able to take them to at least few years. So and now what is the new? So few things I have selected. Already screening has been discussed, but I missed the full lecture, so I don't know whether it was discussed or not. So here is an image. I will go practical. All the slides will be only of practical importance. No theory will be there. So this is a common mammogram, and if you see this mammogram alone, I don't think so many of even the radiologists also, sometime even the oncologists who are daily seeing the mammogram can miss the feature. So there is one thing known as 3D tomomammogram. So what they do it, you can see here, there was a lesion which is not very suspicious on the 2D mammogram, but if you see 3D tomomammogram, you can see it is better defined. So this is the technique of similar technique, what we do in X-ray and CT scan. So this is the tomosynthesis they use, and when they combine it, the sensitivity and specificity is very high. You can see another example here. Here the image, it is a 2D image. When we take it into the 3D, you can see a lesion is here which can be detected. So tomosynthesis reconstruction is a new thing, but the important is, where should we use it? Can it be used in daily practice? What is the availability of this modality? So actually in our hospital, we have this facility, but we use it judiciously, because everybody who is coming, we cannot. The patient is having suspicious, you are clinically feeling there is something and dense breast, but you are not able to figure it out with the 2D images. So this modality is very good. But the problem is, when it comes to the 3D, there is little dose of radiation is high. So use of this modality in the screening, we are not sure, but definitely it has proven it is better in sensitivity and specificity wise than the 2D images. So tomosynthesis is a new thing, and it is now rapidly being used in many centers which are doing the breast imaging and treatment. Second, so again, surgical, what new we are doing? So surgery is the field which grows very slowly. If you see and compare our medical oncology, there's nothing in a daily, around in 2 or 3 months, they bring some new drug, they do some new research, but surgery moves very slowly. So what we always, because we have to put something from the surgery, being a surgical oncologist, I kept this thing. So we know about the breast reconstruction, we know about the breast conservation, but this is a peculiar case. You can see she was a very young girl. She is married, 36-year-old lady. What marked here was a breast cancer detected here. What is peculiar in this? She is having ptotic breast, large breast coming just near the umbilicus. When we treat these type of patient only with the surgery, whether it is conservation or plastic reconstruction, the problem is with the opposite breast. What happens when we do conservation? We need to give radiation therapy. Radiation therapy is a concern is not only this one breast, the other breast also we have to take care of. So it interferes a lot with the radiation therapy. So these kind of patients, what we do is, so you can see here in this patient, bilateral reduction mammoplasty. So reduction mammoplasty, why do we do it? And the procedure I have written here down, wide excision plus sentinel lymph node biopsy plus bilateral reduction mammoplasty. I hope our esteemed audience must be aware of the sentinel lymph node biopsy. So I'm not including it here. So just in short, to avoid the complication of the lymph node dissection, we do not do full lymph node dissection. There is a technique known as sentinel lymph node biopsy in which we inject a dye and just sample the nodes which are picking up the dye. So this procedure was combined with the wide excision and bilateral reduction mammoplasty. So see, this is the final result. So this case, I am not presenting to show a plastic surgery skills. This is whenever a lady is coming with a huge ptotic breast, doing surgery alone for a single breast is not enough. We have to take care of other breasts. You can see both the sides surgery has been done, and actually the patient has completed the treatment and she is very happy with the size of the breast, because indirectly many ladies we see they come with a severe back pain, and they come with the people just keep on clinician keep on investigating the cause of the some cause in the spine and all, but these ladies are actually symptomatic because of the heavy breast they are carrying, and because of that weight they often feel back pain. So this was a happy patient of this surgery. So this is something, it is not new, but we should keep in mind. So that's why I kept this case here. Next comes the radiation therapy. So radiation therapy is when we talk as an oncologist, when you talk to some patient, when we tell them there are 4 modalities of treatment and now it will take around 9 months of the treatment. The first thing is they feel, whoa, 9 months of my life will go in this treatment. So at that time, what the radiation treatment is, classical radiation treatment is usually 1 month procedure, but now 2 things have come. There is a now accelerated radiation is there, in which the radiation duration has been reduced, and this particular case is known as intraoperative radiotherapy or brachytherapy. So what we do, this cannot be done for all the cancer. There's a criteria, size criteria. There is certain thing, lymph node should be negative, tumor should be less than 3 centimeters of size. There should not be any adverse features in the histopathology. So what we do again lymph node sampling, the way I have discussed in last case. We do wide excision, and you can see these wires have been put. They are looking horrible, but same time when we finish up the surgery, within 7 days patient finishes their treatment, and that's all. They need not to go again for the radiotherapy. So it saves time. It's a mental trauma, or psychologically patient finishes the treatment in one go in 10 to 12 days. So this is intraoperative radiotherapy or brachytherapy for the breast. Next thing, one little hope is there, because again the patient, the biggest concern for them is with the chemotherapies, side effects of the chemotherapy. So if we earlier the guidelines were there 1 centimeter, then it reduced to the 0.5 centimeter. The tumor size is, even if 0.5 centimeter, we have to give them adjuvant chemotherapy. So now the gene profile tests are there. The gene profile tests are available for more than 10 or 12 years. But now the good thing is it is now cost effective, available in India also. Our own patient from this small town are also affording these treatment now, this test now. So what is it is a gene analysis. In the tissue, they see the highest genes. If those genes are present or not, they give a scoring system. So if these are lying, the ladies who can be benefited by this, the ladies node negative, hormone positive meaning estrogen and progesterone positive, and HER2 negative. So these are the markers we always do, immunohistochemistry we do for the breast cancer patient. And this is the criteria, this is the category of the patient. We can make use of this Scan assist is an Indian form of this gene profile assessment. It is widely used in India now, and these patients can be put in that scoring system. And if the low score, patient can be kept on hormones alone. We can avoid the chemotherapy. So this is important, which all of us should know, because it happens. The patient comes and asks whether how come we can avoid. So we can just give them then this input. There are few tests which can help them to avoid chemotherapy, and they can prognosticate the future also. So these are the small things I took from the breast cancer. Now I would like to move to the next, an important cancer, ovarian cancer. If you ask me particularly, which is worrisome among both these ovarian and the breast cancer, so that I'll just choose for the ovarian cancer, because we lose many lives with the ovarian cancer, because breast is actually an organ which is outside. Even if something late they come, they at least diagnose it themselves. But the ovary cancer is still a dreadful disease, very fatal disease, and we are losing many patients. Around 70% of ladies are presenting in the stage 3. So what is important here? I always start whatever is my topic. If somebody is asking me to present on ovary, this is my one favorite slide, which I never want to miss. I'll suppose why, because this is a very common scenario. I think all of our audience who are here, they must have seen this ovarian cyst. So one thing, I'll start with this slide and I'll go ahead with other things. So whenever an ovarian cyst has come, so dealing with the ovarian cyst decides the future of a patient. Recently, I am about to operate a patient after 2 days. Similar situation, the big ovarian cystic mass was there, and it was aspirated, and some spillage was there. So whenever you see an ovarian cyst, these are the methods. There are multiple methods. Whatever we do, we should try not to rupture the capsule. So what I am doing here, I am just, after puncturing, I am just sealing that hole. It can be done. You can just cut it from the pedicle, put it inside the endo bag, and then aspirate it. Never think, okay, it was a simple cyst, all the tumor markers are negative, need not to worry. It can be a simple mucinous cyst. Never take it for granted, because it happens in this large cyst. Sometimes the radiology also is not that helpful. When we take them for the histopathology, then only we understand. So one ovarian cyst treated properly can save many lives. So just don't hesitate to open. There is nothing wrong in opening a patient, rather doing a spillage, because these are the things, because it's inside the peritoneal cavity, and we never know where was the tissue, where was this, that the seed cells are getting deposited. Because in few more slides, what I'm going to show is the thing, if it has not been dealt properly. And again, when you're taking out, always take it with a, we take it in a endo bag. It was not a classical endo bag. It was a only simple Euro bag, and we can make it. It's not a very costly affair also. And then you have to close the suture line properly, so that to avoid the future herniation. And I have seen the tissue being there, all this mass is being delivered fragilely. That also should be avoided, because sometimes that is the area involved. It can rupture, and it can cause a deposit in the POD. So ovarian cyst should be dealt with the care. It should be properly investigated. If you do not want to open full abdomen, at least small phalansteal control aspiration, and then only we should take it out. So again, I'm going for the practical things only here. So what happens? Another small video I have kept here. So how should we deal? This is the current thing. Most of the centers in the oncology, they deal it. So what next I'm going to show is a frozen section. So what we do, we take out the ovarian mass, send it for the frozen section. What is a frozen section? This is not for ovary. I'm showing it for a lymph node. So the pathologists cut it down there itself in the lab. They put inside, there is a special chamber for this frozen analysis. They freeze the tissue, so it becomes very hard. Because what we do regularly in the histopathology, we put in formalin hardens the tissue, they cut it and make slides, and then do staining. Here what they are doing, on table, frozen section, pathologist section the full cystic wall, take out the suspicious area, and just put it for the frozen section. It is not very sensitive for the ovarian cases, but at least in 70 to 80% of the cases, correlation is there. We ourselves have a study of our own center, and it was correlating around 80 to 90% of the cases. So if you have a facility, please use for the ovarian masses. if it comes out to be malignant, you can finish up the staging at the same time. And now I'm going to show a video. So this is thing, and now I'm going to the advancement. So what happened now if the patient is coming in advanced stage? I told the most 70% to 75% of the ovarian cancer, they've come in the advanced stage. So how do we deal with them, and what is the current way? We have to do, this lady has come with the ascites, the tumor markers were around 1000, CA125 is around 1000 of the range, which normal is 35. So we take them for the staging laparoscopy, you can say diagnostic laparoscopy. What special is here? You can see all the ports are in midline, none of the ports are in the flanks. So what we are just mapping the disease, which is known as PCI, peritoneal carcinomatous index, which has been defined for the tumor which are extending to the peritoneum. Those are like ovary, stomach, colorectal, all these are pseudomyxoma peritoni. So what we do, we just see the whole abdomen, and we have divided the whole abdomen in different quadrants. Each quadrant has a score. So then, this scoring is why it is important, because in most of these patients will receive the chemotherapy. When we go again in, we will not be able to know where was the initial disease was. So this is a norm to do a diagnostic or staging laparoscopy for these patients who are coming with the ascites with high CA125. We should not attempt, or we should not treat them without any biopsy or this mapping of the disease, because this is the norm nowadays for the ovarian cancer surgery. What you are seeing here, I just want to project here. When we do final surgery, we take out all the midline scar. You can see in the first video I have shown, these all we have to excise when we take the take up the final surgery, because in around 45 to 50% of the cases, this can be a site of the tumor deposit in future. So this is a little long video, but I'll just show in short. So what is currently indicated surgery? What ideally we should do? No more TH, BSO, omentectomy is enough for the ovarian cancer. Those are the gone days. Any surgeon who is involved in the treatment of the ovarian cancer, they must be aware of the cytoreduction surgery. What do we do? There are two or three protocols for that. One group believe in the doing that. What I'm doing is here is a peritonectomy. So we know the peritoneum is the largest inside the. Its a lining is a very large, and it's one of the organ which is one of the largest organ in our body. And now peritoneum is considered a separate organ system. So that's why people are doing peritoneal surface oncology separately. So what we have to do, we cannot take out we are taking out parietal peritoneum here. All the quadrants, it is from the near the diaphragm, both upper right and left diaphragm. This you can see I'm going from the right pelvic to paracolic area. Full peritoneum peritonectomy we have to do. It takes around 10 to 12 hours to finish the surgery. And in which cases we are doing? Again, there are two protocols. If the patient, this you can see in the diaphragm, right diaphragm, my hand is on the liver, and just we are taking out the full peritoneum, because these are the area when there is a flow of the cancer cells, they go around from the appendix to the Morrison's pouch to the diaphragm, then falciform is there. So this is actually technical and very methodical anatomical dissection we have to do here, because then only we can give best cure. Because till now for the ovarian cancer, how well you do the surgery, it is very important. If we leave behind some microscopic, gross disease, then the chances of coming back are very high. What you see here, it is a Glisson's capsule I'm taking out. That was a cautery dissection. This is a finger dissection. So when capsule is thick, you can just peel it out. And these all, I said, this is the part of peritoneum. Definitely we cannot take out the full visceral peritoneum, but we take out when there are deposits, we take out the mesentery of the bowel. So this is complete peritonectomy, and just a glimpse on how sometimes the specimen. So this lady had was treated with chemotherapy, and she was actually misdiagnosed with there was a confusion outside. She was diagnosed with a appendicular primary, because these are the two things nowadays. Current thing is all mucinous pseudomyxoma peritoni are being originated from the appendix rather from the ovarian mass. So see, the ovarian mass was there. appendix was also involved. So after doing IHC only, we could understand, okay, what is the primary site. So you can see the huge specimen. We took a total colectomy for this lady, uterus. All these are small uterus, and taking out ovary is no more a surgery for the ovarian cancer. So all the caudate lobe, peritoneum, lesser omentum, greater omentum, pelvic lymph nodes, retroperitoneal lymph nodes, peritoneum from the both paracolic gutter, peritoneum from the pelvic gutter, peritoneum from the diaphragm, from the Morrison's pouch, gallbladder, appendix. All these are sanctuary site for the deposition of the ovarian malignancy. And when the patient is presenting with a stage 3, we have to do. And now I am showing you, must be again, our audience must be aware of this, or may not be, because this is new in not new, but now very commonly being used in the oncology. And there is a randomized trial which has proven after the OV-HIPEC trial, which has shown that after the use of chemotherapy, we have to give some form of intraperitoneal chemotherapy. What you are seeing here is a device. These are the tubings being connected. After that surgery, which we have finished, cytoreduction, we have to give chemotherapy inside. What you are seeing here, we have just put the chemotherapy in heated normal sunlight. So its temperature goes up to 40 to 41 degrees centigrade, and we keep it for the 60 to 90 degree in 90 minutes. There are different protocols. We put in as mitomycin or cisplatin chemotherapy. So when we do this surgery, we are not sure whether we have left behind some microscopic disease there or not. So this is additional assurance that, okay, the microscopic disease has been taken care. So there are multiple, I told you in the beginning, there are many diseases which are going to the peritoneum. Ovary, we have a proof in a locally advanced ovarian cancer, which is coming in stage 3. Post chemotherapy, patients should receive, and they have shown the survival benefit of around 15 to 20%, which is a huge in our oncology field. Another new thing, this is actually a very interesting thing I am going to show you here. So this is another form of intraperitoneal chemotherapy. These patients are the patients who are somehow unfit for this HIPEC or any surgery. So this was a doctor, this was a relative of a doctor. She was a very young lady. What here we are going to show you is, first photo is of the first diagnostic laparoscopy. You can see the disease everywhere. The problem with this lady was she was fit, but her mesentery, the deposit was at the root of mesentery. When the root of mesentery is involved, we cannot operate, we cannot do complete resection, which is known as CC0 in our language. Complete cytoreduction we cannot do. So what we do, we take the biopsy to prove that what. Now you can see there are two ports only, and these are we are balloon trocar, so that air should not leak. This is the latest thing what we can do. This is a CT injector. I'm showing it here. 2 drugs are being filled inside this injector. This is my colleague, Dr. Aruna, and myself. We are coming out of the theater. Nobody should be inside the theater, and everything will be monitored from the outside. So patient is inside alone. The full system is done. Then we'll close this thing. And this is a capno pen. What is it doing? It is delivering the aerosolized form of the chemotherapy. So what does it do? The penetration of this aerosolized chemotherapy is very high. So this goes and directly affects. So there is a lot of research is being going on, and the patient who are not fit for the surgery, it can be any reason. They are moribund, they are not able to tolerate long anesthesia. HIPEC is coming in big way. So it is coming in the neoadjuvant before surgery. It is coming in recurrent cases also when they are not responding. So you see, this is session 2, and you can see the good response was there. The deposit started responding, and this, you can see those deposits were in ball. It is gradually becoming smooth. So we give it at the 6 weeks interval along with the IV chemotherapy. It cannot be given alone. We have to give IV chemotherapy also. So again, you can see the session 3, almost there is reduction of around 50 to 60% in this session 3. You can see the smoothing of the bowel is here. Still, she is not operable. Still, we have not operated on her, but you'll not believe for last 2 years, she's alive. She is going for the work. She is feeling very happy, although disease is still inside. And we are treating her with maintenance form of targeted therapy. And session 4, almost visibly, there was around 70 to 80% response of the disease. So this is important Still, we don't have randomized control trial, but lot of retrospective data, big series are coming in different peritoneal surface oncology from the units, and it may be a future game changer in the ovary and the peritoneal surface malignancies. So, and again, so sometimes it happens when after this therapy, patients are actually ready for the proper cytoreduction also. So this is the methods we can buy time also. So now ovary is basically dealt by two things. One is surgeon, there is role of surgical oncologist and medical oncologist, and in between I can add pathologist. So medical oncologist side, lot of research has been done, and currently earlier the thing was only chemotherapy, the treatments are only chemotherapy based, but now anti-genetic agents like bevacizumab and PARP inhibitors and many other targeted therapies have changed the scenario a lot. The patients are living for long. What do we do them? We do BRCA testing, which was discussed. If they have genetic mutation, they are the candidates who will be benefited by the PARP inhibitors, and it is showing a survival benefit, a huge benefit. For a ovarian cancer in stage 3, if they can live for 5 or 6 years, it's a big thing for them. So nowadays, we are able to tell them, we can give them a good quality of life. So I think this is the, there are many other things to be discussed on these things, but for this platform, I think so we should know what is new, which should not be missed. So I have not bombarded this presentation with a lot of theoretical things. If anything we can discuss here. And with this, I am very thankful to all of you for your patient listening. Thank you.
Deepti, fantastic talk, Deepti.
Thank you, Dr. Deepti, for your excellent presentation and very good. What is available in the modern technology? Because usually ovarian cancer is detected in the 3rd stage only, not like breast cancer. We can detect it early and prevent it. But for those patients inoperable, you are doing a wonderful job. Congratulations. And again, I thank you yourself. And I want to tell that Dr. Deepti is none other than daughter-in-law of Dr. Malliga, my co-chairperson, and they are doing wonderful work. Any questions?
Thank you, Dr. Deepti. Very nice presentation. I recall those days 50 years ago in advanced ovarian malignancies, we used to put Cytoxan at the end of the surgery before closure.
Yes.
Every time we used to do that.
Yes, ma'am. So actually, this is very, if you this is the one topic which all of us, combinedly, all gynecologists and surgical oncologists, until all of us will work together, we cannot get rid of this thing. This is a one dreadful disease, ma'am. All of us has to be sensitized, because the difficult most part is counseling. The lady I am telling, we are going to operate, she was operated. It was a CT scan, was a small strand was there. And actually that small strand was harboring mucinous adenocarcinoma. And the cyst was ruptured. Now the counsel for this treatment is very difficult, because they tell how, because there was only small, the big lump was there, it has taken out, neer katti mattoda irundichi, idike avlo peri operation solranga. Like that is very common statement we listen. It is very difficult to counsel them, and we know that until we do a very extensive surgery, the survival rates are very poor. So that is a norm for the ovarian, and this sensitization should come from all of us. Yes, so that is only my request. I am getting a chance to talk to the all esteemed gynecologists here. My humble request: ovarian cyst has to be treated with utmost care. Never ever think about that lap is the only way for the ovarian. That is the only I feel very happy to do lap and robotic surgery, but this is the only area where it should be judged properly. We should not just yes.
Counseling is very important, because fear of chemotherapy, they jump to alternate therapies and they lose their life.
Deepti, we have more than 200 registration. I think 200 gynecologists have listened to your talk. They will spread the message. Thank you so much.
That is the only, I am really thankful from my heart, because this is a topic very close to my heart. And there are no words to say thanks to all of you. You have given me this opportunity, this platform, ma'am.
Nice.
Thanks.
Shall we move on to the next one? Suganya is ready, I believe.
Yes, ma'am.
Suganya, ready na? Present panama.
Yeah. Start.
They will share the screen.
Judges are also there ready, no? Okay.
Yes, ma'am.
Yes.
Yes,
Suganya,
ma'am.
Shahidi and Priya here, you can, yeah.
Yeah. Start.
Dr. Vanya, please start.
நான் ரெண்டு பேரும் ஒரே ஸ்லைட் போட்டிருக்காங்க.
Slide design is the same for both of them.
ஆமா.
For uniformity.
Good evening, madam. Am I audible, ma'am?
See, there's some
Evening, ma'am.
disturbance in your audio. Please confirm it properly and start your presentation. You can use your headphones if you have.
You can join
Yes,
from
ma'am.
mobile, ma'am. I'm sharing from my end.
Okay.
She has a low bandwidth, I think. Suganya, you can switch off your video and start presenting, ma, so that there won't be any disturbance. Otherwise, your audio is getting cut along.
Now, am I audible, ma'am?
Little bit it is breaking, ma'am. Your voice is breaking.
I joined from the phone, ma'am.
Oh, now it's fine, ma'am. You can start.
Start, Sukanya.
Good evening, madam. Good evening. Am I audible, ma'am?
Yes, yes, you are audible.
Yes, ma'am. Dr. Suganya, assistant professor from Coimbatore Medical College, ma'am.
சுகன்யா ரெண்டு டிவைஸ் ஓபன் பண்ணிருக்கியா?
இது லீவ் பண்ணு.
Ma'am, you can log out
second,
from
1 second.
laptop, ma'am.
And switch off one device. You are opening on both the devices.
Good evening, ma'am. Am I audible now, ma'am?
Yes, yes.
Yes, yes. Please start, Suganya.
Hello. Hello. Good evening, ma'am. Am I audible?
Yes, ma'am.
Yes, yes, you start.
Dr. Vanya, you are audible, please start.
Ma'am, ovarian cancer stands the second most common gynecological malignancy, ma'am. The lifetime risk of getting ovarian cancer is 1.7%, and other women with a BRCA1 and BRCA2 has a lifetime risk of getting ovarian cancer 44%, ma'am. Ovarian cancer is a leading cause of death from gynecological malignancy with a 5-year survival rate of 6 to 22%, ma'am. Ovarian cancer malignancy is usually detected at an advanced stage because of its weight, and with a diagnosed at an early stage, the survival rate can be improved significantly. Coming to the risk factors and protective factors, the risk factors include older age. Mostly the ovarian cancer comes with the age of 40 to 45 to 60 years, and other risk factors include nulliparity, early menarche, late menopause, long period of infertility, PCOS, obesity, genetic factors with BRCA1, BRCA2 mutations and Lynch mutations with high women taking high calorie and high fat diet, tamoxifen, and mucinous tumors has a risk factor of smoking. Protective factors include OC pills. OC pills give about 50% protection in ovarian cancer, pregnancy, and sterilization. Sterilization, we all know that ovarian cancer develops from stick cells, that is serous intraepithelial tubal carcinoma cells, which sheds its cells into the. Therefore, sterilization provides a protection against ovarian cancer and also hysterectomy. Coming to the counseling part of the ovarian cancer, mostly the genetic counselor is involved during the counseling session. During the genetic counseling, the family group discussion will be taken. An informed decision about genetic testing for BRCA1, BRCA2, and other inherited mutations will be given. During the counseling, given certain answers to certain questions, including that whether they will be getting any any cancer during the cancer with BRCA2 mutations like that. There is a hypothesis, there is a development of 6S, that is serous tubal intraepithelial carcinosis from the fimbrium to the ovarian surface. Therefore, the RRSO, that is risk reducing salping oophorectomy, provides a chance for reducing the risk of ovarian cancer. There is detecting an occult malignancy at the time of risk reducing salpingo-oophorectomy. Laparoscopic route is preferred than the open approach. During the risk reducing salpingo-oophorectomy, ovarian artery and vein should be clamped at the level of at least 2 centimeters proximal to the ovary at the pelvic end to avoid leaving any ovarian tissue behind. Along with the risk reducing salpingo-oophorectomy, concurrent hysterectomy can be done in women with the Lynch syndrome because they are getting high risk of getting endometrial carcinoma, and BRCA carriers who are wishing to take tamoxifen for chemoprophylaxis of breast cancer, because tamoxifen can also induce endometrial carcinoma, and women who wish to take unopposed estrogen therapy. RRSO, that is risk reducing salpingo-oophorectomy, can also reduce risk of breast cancer. Women with BRCA1, BRCA2 management. Women with BRCA1 mutation has a lifetime risk of developing ovarian cancer of 35 to 46%. These women can be offered risk reducing bilateral salpingo-oophorectomy after the age of 35 when the childbearing is complete. Women with BRCA2 mutation has a lifetime risk of developing ovarian cancer of 13 to 20%. They can also be offered a risk reducing bilateral salpingo-oophorectomy after the age of 35. It can be delayed up to 45. But the benefit of reducing the risk of breast cancer is lost when we are delaying the age up to 45. In the HNPCC, that is Lynch syndrome, women has a risk of ovarian cancer of 3 to 14%. They can also be offered a risk reducing bilateral salpingo-oophorectomy along with a hysterectomy, because in Lynch syndrome, women have a chance for endometrial carcinoma also. With a family history suggestive of hereditary cancer syndrome, the risk of ovarian cancer is 13 to 15%. These women can also be offered risk reducing salpingo-oophorectomy. This is a teal color ribbon, that is greenish blue color ribbon. September month marks the ovarian cancer awareness month. During that month, we can support ovarian cancer patients and also give create awareness among the general public regarding the ovarian cancer. Coming to the screening of ovarian cancer, there are multiple trials have been conducted to assess which screening method is effective. In PLCO trial, that is prostate, lung, colorectal, and ovarian cancer, study groups were identified. In one group, there is no screening method. In another group, annual CE125 measurement for 6 years and annual TVS for 4 years has been studied. In both the groups, there is no improvement in the mortality. In the UK, that is United Kingdom collaborative trial on ovarian cancer screening, 3 study groups were done. In first group, there is no screening method. Second group, annual TVS was done. In third group, multimodality screening was done. In that multimodality screening, CA125 followed by TVS was done. All these trials show no improvement in the morbidity. This is IOTA guidelines, that is International Ovarian Tumor Guidelines. In IOTA definition, there is unilocular cyst. IOTA definitions include unilocular solid, multilocular solid, and solid. Cystic components with it may be anechoic, low level, ground glass, hemorrhagic, or mixed. Solid material, the presence and size of the solid material or papillary structures and wall irregularity should be studied. Vascularity, shadows, and ascites. Solid component is presence of a structure that has echogenicity suggestive of tissue, but not a dermoid tissue or a blood clot or anything. If there is a wall irregularity, we have to measure the size. Like if the protrusion is more than 3 mm, it is papillary projections. If it is less than 3 mm, it is irregularity. Irregularity means irregular inner wall or outer wall, presence of ascites. 10 simple rules for detecting the malignant or a benign tumor. For predicting a malignant tumor, 5 M rules given. M1 is irregular solid tumor. M2 is presence of ascites. M3 is at least 4 papillary projections. And M4 is irregular multilocular solid tumor. M5 is very strong blood flow. B rules include B1, that is unilocular cyst. B2 is presence of solid components, largest component less than 7 mm. B3 is presence of acoustic shadows. B4 is smooth multilocular tumor less than 10 centimeter, no blood flow. Sahitiman, can you move the slide? Okay. If there is a presence of 1 or more M rules and no B rules, it is malignant. If there is a presence of 1 or more B rules, no M rules, it is benign. Both, if there is presence of both M and B rules, it cannot be classified. None of the rules apply. And if defined as classified category. This is the ultrasonography pictures of 10 simple rules. ORAT scoring. ORAT is ovarian adnexal reporting and data system. In the ORAT scoring, the 5 major categories of ultrasound features, that is unilocular cyst with no solid component, unilocular cyst with a solid component, multilocular cyst with a solid without solid component, multilocular cyst with a solid component, and solid lesion with the presence of solid tissue more than 80% of the tissue. In IOTA classification, the color score is graded from 1 to 4, from no blood flow, minimal flow, moderate blood flow, and marked flow. Next slide, ma'am. Next. Sahiti madam, next slide. Then we, next slide, ma'am. Next. Next, ma'am. Sahiti madam, next. We have to assess the ovarian adnexa. If the ovarian adnexa is normal, that is presence of a cyst with less than 3 centimeters, it could be a follicle or a corpus luteal cyst. If there is a lesion, we have to assess the nature of the lesion, whether it's a cystic or a solid lesion. If it is a cystic lesion, we have to assess the lesion, whether it's unilocular, multilocular, or classical benign cystic lesion. The classic benign lesions include hemorrhagic cyst, endometrioma, dermoid cyst, para-ovarian cyst, peritoneal inclusion cyst, and hydrosalpinx. If it's a hemorrhagic cyst, endometrioma, or dermoid cyst, we have to assess the size. If its size is less than 10 centimeters, it belongs to ORAT score 2. If it's more than 10 centimeters, it belongs to ORAT score 3. Para-ovarian cyst and peritoneal inclusion cyst and hydrosalpinx of any size belongs to ORAT score 2. If it's a unilocular lesion, we have to assess the inner wall, look for internal septa, and measure the size of the lesion. Unilocular cyst with a smooth inner wall with no echoes and no septa, it is a simple cyst. Unilocular cyst with a smooth inner wall, and whether if it has an internal echoes and a septa, it is a non-simple cyst. With a unilocular cyst with smooth inner wall and simple cyst, depending upon the size, if its size is less than 10 centimeters, it belongs to ORAT score 2. More than 10 centimeters, it belongs to ORAT score 3. Unilocular simple smooth cyst with a smooth inner wall, non-simple cyst, size less than 10 centimeters, belongs to ORAT score 2. More than 10 centimeters, belongs to ORAT score 3. Next slide, ma'am. If a unilocular cyst with irregular inner wall, we have to measure the size of the irregularity. If the size of the irregularity is less than 3 mm, it belongs to ORAT score 3. If the size of the irregularity is more than 3 mm, it is called papillary projection. If there is a papillary projection, we have to count the number of the papillary projection. If it's less than 1 to 3 papillary projection, it belongs to ORAT score 4. If it's more than or equal to 4 papillary projection, it belongs to ORAT score 5. Then coming to the multilocular cystic lesion, in multilocular cystic lesion, we have to assess the contour of the inner wall and the septa, the presence or absence of the solid component. If the multilocular cyst with a smooth wall and septa, no solid component, we have to assess the color score. If the color score is from 1 to 3 and the size less than 10 centimeter, it belongs to ORAT score 3, and size more than 10 centimeter, it belongs to ORAT score 4. Multiloculated smooth inner wall and septa with no solid component with the color score 4 of any size belongs to ORAT score 4. Multiloculated cyst with the irregular inner wall and septa and the presence of solid component with of any color belongs to ORAT score 4. If there is a presence of solid component, we have to assess the color score. If color score is from 1 to 2, it belongs to ORAT score 4. If color score of 3 and 4, it belongs to ORAT score of 5. If there is a solid lesion, we have to assess the outer contour and color flow. If the outer contour is irregular, it belongs to ORAT score 5. If the color flow is 1, it's ORAT score 3. Color flow is 2 to 3, ORAT score 4. Color score is 4, it's ORAT score 5. If the ORAT score lesions 3 and 4 lesions, there is associated with ascites and peritoneal nodules, it directly come under the ORAT score 5 lesions. Management depending upon the ORATs. ORATs 1 score, there is no need for follow-up. In ORATs 2, simple cyst with less centimeter, no need for any follow-up. ORAT score, simple cyst 2 with a simple cyst with less than 5 centimeter. In premenopausal woman, there is no need for follow-up. In my postmenopausal woman, we have to follow up in next 1 year. With a size less than 6 centimeter in premenopausal woman, we have to follow up in 8 to 12 weeks. Whereas core 2 with a non-simple unilocal smooth inner wall, with a size less than 3 centimeter in premenopausal woman, there is no need for follow-up. In postmenopausal woman, even if the size less than 3 centimeter, we have to follow up in the next 1 year along with the MRI or an ultrasound radiology department. With a size less than 10 centimeter, we have to follow up in 8 to 12 weeks in case of premenopausal women. In WARADS 3, we have to manage with the gynecologist. WARADS 4 and 5, we have to manage with the along with the gynec oncologist. Coming to the Roma score, Roma is risk of ovarian malignancy algorithm. It is a combination of CA125 and human epidermal antigen 4. ROCA is a risk of ovarian cancer algorithm. It includes the serial measurement of CA125. OvaSure is CA125 and includes 6 analytes. OvaSure, it's OVA1. It is a FDA approved multivariate index assay which includes 6 analytes, that is apolipoprotein A1, beta 2 microglobin, CA125, prealbumin, and transferrin. In ovarian cancer, beta 2 microglobin and CA125 will be increased. Another second generation FDA approved second generation multivariate assay, OVIRA, it also includes 5 biomarkers. It is used when the OVA1 is inconclusive. Instead of beta 2 microglobin and prealbumin in the OVIRA, human epidermal antigen 4 and FSH is included in OVIRA. RMA score, that is risk of malignancy index. RMA score includes 3 pre-surgical features, that is CA125, ultrasound features, and menopausal. It is a multiplication of ultrasound score, menopausal status score, and CA125. Ultrasound features include multilocalitasis, ascites, solid areas, bilaterality, and metastasis. Each one is given a score of 1. RMA risk of malignancy index has a 4 scores, RMA1, RMA2, RMA3, and RMA4. If the ultrasound score has no feature, it is given a score of 0 in RMA1, but in RMA2, 3, and 4, a score of 1 is given, even if a score of 1 is given in RMA 1, 2, 3, and 4. With more than or equal to 2 features, a score of 3 is given in RMA 1 and 3, and 4 is given in RMA 2 and 4. Depending upon the menopausal state, if the woman is premenopausal, a score of 1 is given in all the scores, RMA 1, 2, 3, and 4. If it's a postmenopausal woman, a score of 3 is given in RMA 1 and 3, 4 is given in RMA 2 and 4. Size of the muscle is included only in the RMA 4, ma'am. A score of more than 200, it's a definite malignant ovarian malignancy. Tumor markers involved in the diagnosis of ovarian malignancy is CA125, CA19.9, CA15.3, CEA, and human epidermal antigen. CA125 is also increased in other conditions like endometriosis, TB, colon cancer. If CA125 is more than 35 in postmenopausal, it is we have to suspect malignancy. If CA125 is 200 in premenopausal, we have to suspect the malignancy. Other tumor markers in germ cell tumors include alpha fetoprotein, HCG, LDH, placental alkaline phosphatase, alpha fetoprotein, inhibin. Inhibin is increased in granulosa cell tumor. Screening programs are very ineffective in case of ovarian malignancy because of the silent nature of the ovarian cancer and the absence of any precancerous lesion, low prevalence, and non-specific symptoms of ovarian malignancy with bladder and bowel disturbances only. So because of this ineffective screening program and the non-specific symptom, usually the ovarian malignancy is diagnosed at a later stage and it carries a high mortality rate. If it's diagnosed at an earlier stage, the survival rate will significantly improve. Thank you, ma'am.
That is a nice presentation. I want to ask one question. See, you studied so many markers. So what according to you done in practice, in clinical practice?
Clinical practice, we are doing CA125, ma'am. CA125 for epithelial cancers in advanced, in elderly women. If a woman is coming in younger age, we have to suspect germ cell tumors and do also like alpha fetoprotein, HCG, inhibin, LDH, like that, ma'am.
Okay, for screening, what should we do? For screening markers, we should be starting with CA1.
Yes, ma'am. If a woman with adnexal lesion, we have to start with the CA125 and transvaginal ultrasound to assess the size of the mass, ma'am. You have to start with that, ma'am.
Okay.
Because in the Roma-Rocco screen also, the CA125 and transvaginal ultrasound we are doing, ma'am. But even with the CA125 also, it will be bleeding.
Okay. Okay. What is you said you will do the clinical palpation. Okay. Can you tell what is PMPO, postmenopausal palpable ovary syndrome? Postmenopausal palpable. What is PMPO?
I'm not aware, ma'am.
Okay, thank you, doctor.
Very nice presentation,
Thank you,
Suganya.
ma'am.
Very extensive, but
Thank you,
as my co-judge would agree, not very practical for us practicing obstetricians to apply to.
Okay, ma'am.
As Madam was asking, in a patient with a positive family history, how
Okay,
would
ma'am.
you recommend for screening for ovarian cancer? When there's a first degree relative who has
Yes, ma'am.
been affected with the disease.
Okay, ma'am. Annual transvaginal and C125 markers. Annual transvaginal ultrasound and C1.
Annual transvaginal scan from what age is generally recommended in these high-risk women?
High risk women. No, I don't know.
Usually, after the age of 35 to 38, they have to be subjected to the annual screening. And
Okay,
as you said, risk-reducing salpingo-oophorectomy may be offered
Yes,
to
ma'am.
these women as well, especially when
Yes,
there is
ma'am.
a strong family history.
Yes, ma'am. Restricting salpingo-oophorectomy is done after the age of 35 or before the child family is completed, ma'am. In BRCA1, BRCA2 mutation carrying women.
Thank you, Dr. Suganya.
Thank you, ma'am.
Paucity of time, we won't have much time to discuss. We're already running late, I think.
Thank
Sampath
you.
ma'am, shall I launch second question, ma'am?
Yes, thank you for Dr. Nidhi Sharma and Vijay Lakshmi for I'm torturing them every month, I think.
We are also learning a lot along with them, madam.
Thank you, Vijay and Nidhi. Yes, Sahiti, go to the second question.
Okay, ma'am.
This is for delegates. Cancer diagnosed at a later stage and dangerous with poor prognosis is CA breast, CA ovary, CA tube, CA uterus.
Delegates ரொம்ப simple questions ஆ இருக்கு.
Very simple questions.
கேட்க வேண்டாமா?
இல்ல பேனல்ல வந்து கடைசியா தான் கொஸ்டின் 2 கொஸ்டின் தான் எப்பவுமே இந்த அவேர்னஸ்க்காக they should have அதுக்காக போட்டது 2 கொஸ்டின் 2 பிரைஸ் தான் இந்த வாட்டி ஸ்பெஷல் பிரைஸ் 3.
Okay, fine.
Revati madam, next time learn the panelists also can participate in மாதிரி சொல்லி ஒரு special prize for panelists.
அது வேண்டாப்பா, we have to encourage youngsters. இல்ல நம்ம வந்து இந்த லெக்சர்ல வந்த கொஞ்சம் difficult or updated mattersல question வந்தா இன்னும் நல்லா இருக்கும். How much they have listened and learned, அது தெரியும் அப்பதான். ரொம்ப
simple. Become something like a pre-test and post-test question, and it will become a little, you can really assess whether they have listened to the lectures.
பண்ணிடுவோம் சம்பத்.
தீப்தியோட டாக் ரொம்ப நல்லா இருந்ததா? சரி, அட்லீஸ்ட் ஓவேரியன் கேன்சர் அவேர்னஸ் ஆது இருக்கணுமே இந்த
correct.
It's a very eye-opening talk on
nice that in our area, in our place also things are being done like this. அதுதான்
நாமக்கல்.
அதான் நாமக்கல்.
Okay, madam. Thank you. We'll go with the third session. Radhika, introduce the moderator and the panelist.
Okay, ma'am. Moving on to the third session, panel discussion on lumping breast and adnexal mass. May I invite moderator Dr. Shanti Gunasingh madam, who is a consultant in OG, past president OXY, former director superintendent Institute of Obs and Gynae, ISO KGH, former HOD and OG, Kilpak Medical College, and she served as Project Director, Center of Excellence for Tubal Microsurgery for 6 years. And she has been the past president, Women Doctors Association, Tamil Nadu. The panelists, I invite Dr. Tamil Godai Madam from Tirunelveli Medical College. She has excellent 22 years of teaching experience, currently professor in Tirunelveli Medical College. And she has received Best Doctor Award thrice, published many research papers, and she's in the curriculum committee, member in Tirunelveli. I invite Dr. Poonkodai Arul Prakash Madam from Tuticorin. She is the president of FOGSI in Tuticorin. Voluntarily, she has retired voluntarily from Tuticorin Medical College, has received Collector's Award for Family Planning Achievements. She has special interest in Tamil. According to her name, Vice President of Tuticorin IMA, Best Women Doctor Award IMA, conducted community awareness programs at schools, colleges, and villages. I invite Dr. Anita from Kanchipuram. She's a senior assistant surgeon at Government Headquarters Hospital, Kanchipuram, has done her UG at Madras Medical College, DGO at KGH, and MSOG at Government Teni Medical College. Next, Dr. Prabha Swaminathan, Dr. Swati, who's completed UG and PG from Tanjavur Medical College, worked as assistant professor in Tanjavur Medical College and working as a consultant at NM Hospital Private in Tanjavur. And she's interested in gynae endoscopy. I invite Dr. Vimala, Madam. She's a senior assistant professor, Institute of General Surgery, Madras Medical College and Hospital, Chennai. And she has done her MS in Kilpak Medical College. And she has a few journals to her credit, in articles in few journals to her credit. Shall we move on to the Dr. I invite Dr. Prabha, who's completed MD-OG in 1992 from Ahmedabad, has a wide exposure of working in rural and urban areas across various sites. She's a professor at CHRI, has 30 years of experience in this field, and she's currently a consultant at Dr. Rayla Institute. And her areas of interest are innovative teaching methods, child sex abuse protection, cancer prevention, intimate partner violence intervention and prevention, reduction of maternal mortality, breastfeeding initiatives, and most favored is women empowerment. Has publications in numerous international national journals and has authored many chapters in books. Can we please start the panel discussion?
Thank
Shanti
you.
Madam, Vimala Matta, surgeon Madam.
Amappa, pesnappa. Okay, thank you.
Okay.
So, surgeon plus physician.
Yeah,
Yes,
DGO
yes.
surgery, DGO MS surgery.
அதுக்காக தான் அவளை கூப்பிட்டேன். இருந்தாலும் சொல்றேன்.
Yeah, I thank Professor Sampath Kumar and Professor Revathi Madam for having given me this opportunity. I will share my presentation. Yeah. Can you see my slide?
Yes, yes.
Yeah. So the topic given to me is lumps in breast and adnexal masses. So we will make it very short because we are running late. So this Indian Express recently, it carried an article, breast cancer in Chennai women doubled in 7 years. So this was noted by the Tamil Nadu Cancer Registry. Tamil Nadu is one of the states where we have good cancer registry. And for 2016 to 18, it showed that the crude incidence rate of breast cancer among women in Chennai was 52 for 1 lakh population, which means it has really doubled within 7 years. So that is really huge. Maybe because of awareness or it really, the incidence was more, we really do not know. So case 1 is, we will straight away go to our case. A 22-year-old unmarried girl reports with a lump in the left breast, 3 into 3 centimeters. Okay, so generally all these women and girls come to OGCN only. So I think first we will take up any OGCN can volunteer. So how do we go about this? Anybody can take it.
I'm Dr. Prabha.
Probably
Usually-
what we can do is, the OGCN can take it. When we come to a diagnosis, initially, before that, we will have a differential diagnosis. So what can be the differential diagnosis of palpable breast mass? So surgeon also, Amma, take it. Vimala? Is Vimala
Are
there?
they different?
Common thing is, yes, madam. Common is a fibroadenoma is the commonest. Hello, good evening, ma'am. Are you able to tell me?
Yeah, you
Hello?
heard,
Hello?
Amma?
Yes, madam. Yes, madam. The commonest actually
Yes.
what we are facing is a fibroadenoma is a non-proliferative disorder, madam. That is comes around 25 to 40 years more common actually. But once patient fibroadenoma comes actually, the chance of malignancy is not there actually. We can reassure them and we can do a ultrasonogram. After that, actually do a every 6 months for 1 to 2 years. If the size is increasing, if it is more than 4 centimeter, okay, then we can go for a surgery. Otherwise, we can reassure them, or if the age of the patient is more than 30 years, or if they have any family history of family members suffering from breast cancer, then we should go for a surgery at the earliest. Otherwise, if it is less than 3 centimeter, fibroadenoma, do ultrasound and we can observe the patient. And if it is a fibrocystic disease, it's mainly a hormonal thing. If it is a large cyst more than 3 centimeter, we can go for an aspiration. If it is a record, even you can go for repeat aspiration and do ultrasound after 6 weeks and see the size of the mass. And you send for the fluid analysis, whether it's a clear fluid or bloody fluid. If it's a clear fluid, we can observe it actually. If it is a bloody fluid, actually, we should go for whether it is atypical changes is there. If it is atypical hyperplasia, we should observe them and see that we have to do if it is more than 35 years, then we can go for a mammography. If it is less than 35 years, ultrasound is not able to detect, then we can go for a MRI with the less than 35 years.
Yeah.
And for the fibrocystic disease treatment wise, it's only a hormonal thing, so we can go for a evening pyrimethamine, vitamin E, and pyridoxine.
Yeah, although literature doesn't support it. Yeah.
Yes, madam. But if at all the hormonal wise, we can go for danazol, tamoxifen, LRH agonist, that and all we can go, madam, actually. That is very rarely, still they are not intolerable. So otherwise, we can give reassurance. Only about the old age, more than 40 years, we should give important. Less than the younger age group is not going to be a problem. And galactosylus actually, if there is a galactosyl, only a duct is getting blocked, we can go for a aspiration. And even if it recollects, you can go for a repeat aspiration. Once, twice aspiration is done, still it is not controlling, then you can go for a ductography and clear the duct where it is blocked, that can be cleared with a nylon suture material can be done. And fat necrosis mainly at the old age, it will actually mostly around more than 40 years is more common. That's mostly a traumatic fat necrosis, the hard in consistency. So younger age is very less. And breast cancer also, most of the time they'll present with the mastite is the common presentation, but the abscess actually as such mainly for the lactating woman actually. So mastitis we can cyclically we can, whether it's a cyclical or non-cyclical, we have to see whether it's a post-menopausal symptoms or anything. We can have a cold compression, anesthetic patch, they can be applied, or you can, if still intolerable, they can go for a occipitals. But if it is gone for the breast abscess actually, then we have to see for what is first aspiration, and we can for a culture sensitivity. So in olden days, anywhere abscess we'll do IND, but in recent studies there is no more IND, so we have to go for a ultrasound guided aspiration to avoid any fistula, lactiferous duct fistula, and whenever the drainage is, the collection is more than 30 ml, or if it is size of the access cavity is more than 3 centimeters, we can go for a pigtail drainage. So incision and drainage not needed unless it's thick walled or multiloculated.
Yeah. So
And we can go with antibiotic.
It's the commonest
Antibiotic
one.
for
Then galactoseel is not in this patient because she is an unmarried one. Fat necrosis, especially if they have had breast augmentation, that is quite common nowadays. So breast reduction surgery. So all in those patients, we have to remember about this. This can present as a mass. Okay. So the one thing what why I put all these is 90% of breast problems are benign. That we should always remember. So we can have also malignancy. Okay. So how do we go about it? Dr. Vimala told about all these things. Can any OG-cian take it? Because it will come to only a OG person usually. Can anybody take it, Amma? Tamil Kodai, Pungodai? Anybody?
So for the myself will talk, ma'am.
Okay, Pa, please.
So as it is a palpable breast mass, first you have to take the history in detail, ma'am. And what are all the symptoms what the patient is having, we should ask. Whether the changes has come very recently, and what
Shanti
about
madam, ஒரே ஒரு நிமிஷம்.
என்னப்பா?
அவங்க தீப்தி மேடமும் பேனல்ல ஜாயின் பண்ணிக்கிறேன்றாங்க. We will welcome her also.
Yeah, please do.
Dr. Deepthi, you can join.
Yeah, you can always give your opinion.
Yes, ma'am. I'll not just join to give the answer. Only few things in between. If I feel, please allow me to talk. Thank you, ma'am.
No, always you're welcome.
Yeah. Okay.
Yeah, please continue, Pungodai.
Yeah, yes, ma'am. So we have to look for the changes in the breast and whether there is any nipple discharge and what type of that one, and breast pain, and whether it is related to menstrual cycle or not, whether there is any history of trauma, we should ask. Then we should for the risk factors for the breast cancer. We should taught the patient what are all the risk factors she should find out. And physical examination, we should advise her for the breast self-examination, and complete even clinical examination can be done.
Has to be done. We have to do it. Come to us, isn't it? So
yes,
clinical breast examination, comprehensive clinical breast examination is mandatory. Okay.
Yes, it has to be done. And the breast nodal, we should look for the even lymph nodes also, and documentation and timing of examination to be very clear. And
so that is very, very important. See, it is not, we have to see nodes in the neck, nodes in the chest wall, as well as in both axilla, in upright and supine position. That is very, very important. Documentation is we take the breast as a clock. So 1 o'clock position, 12 o'clock position, like that. And timing of examination is also very important. Whether it's pre-menstrual or post-menstrual. So all that breast changes can be there. And how do you evaluate?
And one thing
how do you evaluate?
Ma'am, one thing I want to add here. So simple formula how for the youngsters, I just want to add here is when we see the breast, we have to see first the breast, then the nipple. There are certain, and the skin, axilla, and never we should forget two things. One is arm edema, another is supraclavicular. We always should put our thumb or hand over both the supraclavicular area because it's a common site of nodal metastasis for the breast cancer. And lymphedema, why we see it? Because when the nodal burden is high, it presents like a lymphedema, madam. So examination, we have to see these areas.
So it can be called as ABC, axilla and breast nodules and collarbone nodules.
Yeah. So this patient, she's only 22 years. So what further investigations will you do?
For the young girl, ultrasonography.
Yeah.
We can have an ultrasound. We can have an sonomammography or an ultrasound, and which most probably a 3 centimeter would be a fibroadenoma, and reassure her.
So
or have it removed
So
or have it
the most important thing is she is very young and she has the effect of hormones on her breast. So her breast tissue will be dense. So we do only ultrasound. And ultrasound also we should understand it's not only for mammography we follow BIRADS, but then for ultrasound also it's very, very important. What is the role for biopsy here? Anybody can take it. Deepti also can join.
Ma'am, I'll listen to everybody and at last I'll talk, ma'am, because this is for me day-to-day work.
I know we are already
actually biopsy
Madam is talking. There is
we can once ultrasonogram is not able to diagnose, we can go for younger age group. With high risk people, we can go for MRI also.
So what do you? No, high risk is different. What I am asking is, she is apparently no family history, nothing. She is 22-year-old young unmarried girl. So will you biopsy or not? Deepti?
Yeah,
No,
yes, madam, we
ideally-
can go for FNAC. That can be done under ultrasound guided. That will be better, madam. Instead of doing a FNAC, you can do along with the ultrasonogram. That will be better. Or if the FNAC comes as a malignancy, then core needle biopsy can be done, madam. Either CT guided or ultrasound guided. Actually.
Ma'am, for young
Because,
age, until clinical suspicion is very high, there is no role of biopsy. In ultrasound, if the features are only suggesting of BIRADS 4 and onwards, then only take up for the biopsy. And these fibroadenomas and all, we should not biopsy because it's a clinical radiological diagnosis most of the time. And if there is telling that some symptoms which is instead of gradually there is a fast growth, then only put them for the biopsy. For a benign lesion which is not suspicious on radiology, we should not do biopsy here, ma'am.
Yeah, this is the message
I agree.
wanted to go across. We have to follow explicitly the BIRADS scoring system, and if it is done well, then if it is the 1, probably it doesn't need at all 1, 2. So all that we have to remember. But then if the score is more, probably an FNAC, ideal would be a core needle biopsy. Surgical biopsy is done only if the skin is inflamed, all that. But the most important thing what I wanted to tell you is imaging should precede biopsy wherever and whenever possible. That is very, very important. So many times a mass is biopsied, and at least for 2 to 3 weeks after that, if we send for imaging immediately, we cannot come to a definite conclusion. At least 2 to 3 weeks later only you can do. So imaging should precede biopsy. How do you manage this patient? We see a lot of girls like this, isn't it?
It is a large mass. It is more than 4.
No, it
4
is about
centimeter,
2 into 3 centimeters, Amma.
Reassurance only, ma'am.
Reassurance. Less than 3 centimeters, you can reassurance, madam.
Yeah, reassurance, okay. What about follow back? Because he will get
we can do 6 months once ultrasonogram. We can do ultrasonogram every 6 months for 1 to 2 years, madam.
Okay.
For normal person. If it is a high risk only, we should go very often.
The most important thing is, see, routinely seeing fibroadenoma, we should not be naive, happy, and exercise. A proper ultrasound evaluation should be done, and accordingly, management should be instituted. This is the message that I wanted to go across. So coming to case 2, 43-year-old woman reports with discharge from the right nipple for the past 6 months. Okay. So what will be the types of nipple discharge? How will you evaluate this patient? She's really worried. All such patients come to us only as a female doctor.
Discharge, you have to ask the color of the discharge, madam. If it is actually serous discharge, mostly a fibrocystic disease can cause the serous discharge, madam. If it's a green color, it may be a duct ectasia can cause. If it's a bloody discharge, maybe a benign duct papilloma, or it may be a malignancy can come as. But if it is, whenever there is a unilateral breast discharge, spontaneous discharge, it should be alarming bloody discharge. If it is bilateral discharge, if it is a serous milky discharge, we can counsel them after their investigation of ultrasonogram. That's a basic thing. So do ultrasonogram to rule out there whether it is a benign or solid lesion is a malignancy, then we can reassure them.
Yeah. And all these nipple discharges, we have to palpate thoroughly and rule out masses too. That is very, very important.
Here, yes, madam, you have put here. So 2 things for the nipple discharge. We have to take a history of what you have put in the slide, what medication she is on, and 1 single sentence I want to add here: copious, sanguineous, spontaneous. If this is the discharge, we have to put them. She's 43. Mammogram has to be done. Ultrasound is not enough. Ultrasound is not enough for this lady.
Yeah. So for anybody, I mean, after the age of 40, with even asymptomatic, we are supposed to do. And she is symptomatic. And as Dr. Deepti said, she has to undergo. So what I really wanted us to know is we have to do a triple assessment. Clinical examination we have done. Some it has to be followed by radiology, and such patients have to be pathology also should be pathological examination also should be done. So discharge should be sent, or if there is a mass, then we have to do an FNAC or ideally a core needle biopsy. All this only after a mammogram. Okay. So
now, one more thing I'll add here. Sometimes it happens, we are not able to see whether it is sanguineous or it is some mixed discharge. So patient is sometimes confused. So what we should do, just although it's not a diagnostic, what we do, we take a slide and just make a smear. This is not to diagnose the malignant cell. It is to confirm whether RBCs are there or not, because DCI is ductal carcinoma in situ, very commonly present as a sanguineous nipple discharge. So always make a slide and ask the pathologist to see for the RBCs, not for the cancer cell. That is one input I want to add.
Yeah. So again and again, BIRATS assessment should be done, which is done both for ultrasound as well as mammography. And then that itself will tell us the likelihood of malignancy. So category 1, essentially 0% likelihood of malignancy. Category 2 also same. Category 3, although benign, then less than 2% likelihood of malignancy. So all that we have to remember. Category 5 and 6, we have to take category 4 onwards, we have to take a tissue diagnosis. Because the chances of malignancy are more. So we should never forget this. Okay. So this is coming to case 3. A 47-year-old woman is worried about cyst in left breast when she went for routine medical checkup. They have done a mammogram, and in that ultrasound, they have mentioned about cyst in left breast. Everybody knows ovarian cyst can be dangerous. Like that, she also is worried whether the cyst in the left breast is dangerous. So how will you proceed? Here I've shown the thing is anechoic, smooth margins with posterior enhancements. So how will we proceed?
Aspiration.
Okay.
Yes.
Yeah.
Fine.
Yeah. Earlier we were talking. Yeah, please do, ma. Pardon?
Ultrasound guided
aspiration
after a mammogram.
Yeah.
After a mammogram, we will.
Mammogram. Only with the report she has come to us.
Okay. So then we have to aspirate a fine needle aspiration. We can do.
We can do after the
after
the investigation, we can do aspiration and see the color of the fluid. If it is a clear fluid, we can observe the patient. If it is a bloody fluid, we should insist the patient to go for a core needle biopsy.
I'll add here something. So the cyst, how we should deal it, we have to categorize into the simple cyst or complex cyst. If there is any solid component, we should do the biopsy from the solid. For the simple cyst, if patient is symptomatic, if the size is big, then only please aspirate, and do not send that aspirate for any cytology, because in a long standing cyst, all cells are showing atypical type of features. So if we send these things for the cytology, always they will report atypical and will misguide the treatment. So please do not send it for any cytology, throw it out. If it is solid component, then guide with the ultrasound and take a biopsy from the solid component. Simple cyst, we just can observe if patient is not symptomatic, ma'am.
Yeah. So it is very, see, radiology plays a very important role. We should have a good radiologist, and we have to categorize it accordingly, whether it is simple cyst, complicated cyst, or complex cyst. Okay. So only 3% of such cysts actually have problems. That is what, and malignancy is seen only in 0.3% of complicated cysts. So it is not that very common. And as Dr. Deepti said, I mean, in simple cysts, which is quite small, which is incidentally found, we need not do anything, but probably we can do an ultrasound guided FNAC if the cyst shows signs of infection or inflammation. Otherwise, no further evaluation is needed. Then you observe them, and so initial categorization is very, very important. So if it is a complex cyst, then an ultrasound guided core needle biopsy, not an FNAC, but a core needle biopsy specimen should be got and then followed up. That is the importance. Now, they're coming to case 4. A 23-year-old lactating woman complains of pain in left breast. So how will we manage? So she already said, our surgeon Vimala already said that better to do it under ultrasound guidance, or at least the most important thing what I wanted to, the message to go across was no IND at all. It is just aspiration. If it is obvious, aspiration as such, or under ultrasound guidance, which is much better, and she has to continue breastfeeding. But if suppose if the same woman is not lactating, then also can she have abscess? What can be the causes?
Yes, she can have an abscess because of a hematoma due to trauma. A hematoma could have got infected and caused an abscess.
So it is more following periareolar abscess, following ductectasia. Tuberculosis in our part of the country, although it is uncommon, it is not that we do not see at all. So that we should always remember. So in that event, probably as
tuberculosis,
excision has to be
done. Come in the old age.
Yeah, but then we have specifically it is given here that even young lactating women can sometimes be affected. It can present as mass lesion, and FNAC can be diagnostic. ATT has to be done, but excision of tissue also has to be done. So
one addition here, ma'am. So this is known as granulomatous mastitis associated abscess. And in these cases are very difficult to treat. And because we see a lot of breasts, so I see almost in a month, 2 or 3 these patients. Yeah. So this we have to properly do excision and then put on, we have to do a sensitivity test for the AKT and then put on AKT, ATT. Yeah.
So I really wanted, because I've seen 2 cases in the recent past. Okay. So
Yeah.
what is the surgeon's role in benign breast disease? It is not knife alone always. I said 90% can be benign. So we have to always think about triple assessment. Malignancy should be excluded. And if we attempt any surgery also, we have to always consider body image and cosmetic considerations. So treatment in a breast clinic, a dedicated breast clinic also matters a great deal. So coming to case 5, 32-year-old woman comes in a worried state since her mother is diagnosed with breast cancer. Wants to know whether she can also develop breast cancer because her grandma also had breast cancer at an elderly age. But then her mother has developed a bit earlier. So she is also worried. Okay. Anybody can take it, Amma?
So you should say, actually, the person actually had a breast cancer, which asked was the age of the diagnosis, madam. If it is less than 50 years, the person had a breast cancer, the chance of heredity is more. And if it is more than 50 years, the chance is less, madam. And if the patient has a first degree relative, then the chance is more, 2 to 3 times more fold is increased compared with normal people. And also, if there is a breast report, what is the hormone receptor? If it is a triple negative, that is estrogen, progesterone, and HER2 receptors negative, then there is a chance of getting heredity is more common, and it will be aggressive tumor also.
Yeah.
So depending upon the age and also to the relatives and also to the pathological types also, the chance of heredity is more.
Yeah, as
compared with
Vimala
other,
said,
and also to the age.
yeah, a proper history taking, finding out about the condition of the affected person, and we should also assess her risk again with all these. These are available online, and Gale model was the first one to come. Then we had this Tyrer-Cuzick model, where they talk at length and breadth about family history, not only about breast cancer, but also about ovarian cancers. So all these things, this is available even for postmenopausal women. It is very, very important to always assess your risk. And especially when this girl is worried, that is also very, very important. What else do you do?
Ma'am, one addition here again, sorry. So the thing is, always when suppose that girl's mother is alive, so whatever we are doing genetic testing should be done in the index case. So if the lady is alive, we should put her for the genetic thing. So this is our norm in oncology, that anybody is coming with a strong family history and less than 40 years, always should go for the genetic counseling, because in a case when she's alive, we can do it better, genetic analysis. So she should undergo.
Yeah. So what are the risk factors for developing breast cancer generally? We talked about, Dr. Deepti said about BRCA1, BRCA2 gene. So genetically, mother and sister with breast cancer, and then age at menarche. So the
early menarche.
They have periods, early menarche, late menopause, all that matters. So
Nulliparity.
Yeah,
Nulliparity.
And the first pregnancy after 30 years.
Yeah. All that is important. And alcohol. So all these things about prevention, probably we can tell about all these things. Okay. So what are the, so this is, she's only 32. Probably she's one of those persons where the double income, no kid group, big group. So she has not had a baby so far. So we can stress about breastfeeding, importance of breastfeeding, giving birth, all these things, exercise, then her maintaining her ideal BMI, all these things are very, very important. So protective factors and oophorectomy always be, there's Angelina. So oophorectomy before the age of 35 years and aspirin. aspirin even more than once a week for 6 months, it seems to be protective. Somehow aspirin is very much tied up with the logicians, I think. Okay. So what is the role for MRI?
She's
MRI actually mainly for the younger age group it is needed, madam. For screening MRI, those people with a high risk from the 25 years onwards, yearly once we can do a MRI and we can diagnose. And those patients with dense breast disease also screening with MRI is done, madam. Otherwise, we can go after 40 years, mammogram is indicated.
Yeah. So MRI we do because mammography, X-ray mammography cannot make out very well in the dense breast because of the hormonal influence. So as Inba Priyanka said, that is anybody who had cancer, we had radiotherapy, we start chest radiotherapy, we start from the age of 25. Others probably we have to start early. And this is the nice guidelines which talked about TP53 gene. I was not even aware of that. From 20 itself, yearly MRI scans. And from 30, we have to for BRCA1, BRCA2 gene. And from 25, for people who have had chest radiation in childhood. So that is very, very important. Okay. And any blood test to detect early blood cancer. Now we have everything for everything. We have one blood test. Do we have any blood test to detect early blood cancer? I mean, not blood cancer, breast cancer. So this, I got it from the Times of India, and this is from our own Adayar Cancer Institute. So they say that they have done a study in patients with breast cancer. There is a reduction in the expression of 3 protective genes, SOST, DC1, WIF1, and DAC2. And that itself, the false positivity was about 9%. So, but otherwise it seems to be good. So after that, we can probably do other tests also, like mammogram, all these things, and come to a conclusion. So at least it is in the offing. So just like our NIPT, probably one blood test will tell everything. Okay. So we have finished our breast cancer, and coming to ovarian cancer, it is the 3rd most cancer in Indian women and 8th overall. 3.4% of all cancer cases. As Sukanya nicely said, leading cause of death among cancer in Indian women, and only 50% are diagnosed in stage 1. Advanced stage ovarian cancer has a dismal prognosis. And this is the ICMR has published one a booklet in 2019. It was essentially for epithelial ovarian cancer, but it gives a good guideline. Okay. So coming to case 6, she is 42 years. She presents with pain abdomen. Ultrasound was done. A cystic mass in left adnexa, 18 into 18 centimeters. So how will you proceed? I think logicians can take up, and Deepti also can chip in. Anybody can take up.
Yeah.
Yes.
Okay, ma'am. So should I?
Yeah.
Yeah, so I can see a thin septa here. So if I am telling about the oncology point of view, 18 into 18 centimeter mass, she's 42. We have to do a next line of imaging. We take as a CT contrast and tumor markers for her because she's 42. These are the basic things we need to do and define more about the cystic thing. There are methods we can see if it is people are ORADs can be given in ultrasound even. So depending on the suspicion level, but as an oncologist, we always do a CT scan and tumor markers, ma'am.
Yeah. So we have lot of cases for as differential diagnosis for an adnexal mass. So it can be gynecological, it can be non-gynecological, it can be benign, it can be malignant. So actually, when we are evaluating, we should find out whether they are asymptomatic or symptomatic. Here, symptomatic pain abdomen. Age also is very, very important. Examination is mandatory, and whether she aspires for fertility. That also, she's 42, but then you can never say. Maybe she's an infertile, subfertile woman who wants to conceive. So all these things we should take into consideration. So we have to talk about this international ovarian tumor analysis criteria, IOTA. So we should see to that our sonologist gives such things, give the report in this format. So that is very, very important. Sukanya nicely talked about all these things. And it's very important that it's just 5 simple rules for benign, 5 simple rules for malignancy. But then if both M and P features are present, then we have to evaluate further. Okay. And Deepthi also talked about CA 125. Okay. Tumor markers as such. And but then we understand that CA 125 can be elevated in many conditions. Can anybody elaborate on that?
CA 125 can be elevated with endometriosis. It can be.
Yeah.
Most commonly, we see it with endometriosis, and it can also be elevated with other epithelial tumors as well as to do with the mesentery, peritoneum.
So adnexa means
benign gynec conditions as non-gynec conditions.
Yeah.
It's a non-specific marker which can all and be elevated in any irritation of the peritoneum.
Yeah. I have seen a case of high CA 125 in a post-menopausal woman, and surgical oncologists had posted for surgery. Her daughter, who's a doctor, was in US, and she was very particular that a preliminary diagnosis should be made before surgery. And then she had some problem and she was taken up for other things. It turned out to be TB peritonitis. Complete recovery was there. So we should remember, especially in TB, it can increase many folds. So all these things we can remember, we have to consider. And non-gynecological cancers also, it can increase. And this IOTA adnex calculator, this is available online. So other things plus CA 125 is what is important. Deepthi talked about ORAS. Okay. So earlier we were using IOTA. Then analyzing that, nowadays we are supposed to, in the US, this is extensively followed for diagnosis, even for management. So this is ovarian adnexal reporting and data system. So this will characterize patients, whether likely to be malignant or how much can be the malignancy and what treatment has to be done. So here you can see this is green. So when after this ORAS is there both for ultrasound as well as for MRI. So here simple cyst. So here nothing is needed. And if it is more than 5 but less than 10, follow up in 8 to 12 weeks. And you have to follow for 1 year. So it not only gives diagnosis, it also tells us how to manage. And that depends on whether they are pre-menopausal and post-menopausal. So I think we have to take up this ORAS very much. And Sukanya talked about risk of malignancy index. What about HE4? Anybody can take it up?
So HE is a new marker for the ovarian cancer.
Yeah.
It is thought to be, it is more specific, but the availability and cost is a problem with this, ma'am.
Yeah, but then see endometriosis also, it looks like malignancy only for us, and CA 125 is very much raised, but HE4 will not be raised in endometriosis. That we should remember. So it really helps in such cases, because many of these patients have been infertile, they've undergone induction of ovulation for long. So probably here, the role of HE4 is important. So when will you refer to Deepti? As OGians, she's our patient, but then I think we have to give a proper treatment too. So when will you refer to a gynae oncologist? Anybody can take it, Amma?
Yes. In the premenopausal group, when the CA 125 is more than 200 units, and if there is ascites there and evidence of abdominal or distant metastasis, there means then we have to refer the patient to oncologist. And another thing, family history of breast or ovarian cancer.
Yeah.
In postmenopausal group, CA 125, more than 35 itself, we have to refer the patient to oncologist. And whether if there is ascites and nodular or fixed pelvic mass and evidence of abdominal or distant metastasis, and there is a family history of breast or ovarian cancer, these patients should be referred to oncologist without fail.
TNFOG recommendation. So postmenopausal, even with mild elevation, we have to. Premenopausal, there can be other confounding variables, so more than 200. And postmenopausal, if it is a nodular or fixed pelvic mass, we have to refer. And Dr. Deepti nicely talked about doing stripping of peritoneum completely. So all that makes a lot of difference, because the mass which is left behind should be really very less. That is, so we talked about staging laparotomy, but then that is only for early cases. Okay. So generally, suppose if it is an early ovarian cancer, then what will you be doing? Anybody can take it up?
Yeah, staging laparotomy.
Yes, when you open, you will first aspirate and send to cytology.
Aspirate what?
This exploration of the abdomen.
So meticulous, we have to see thoroughly, that is most important. Instill saline, and then if there is no ascites, then we have to take washings. If there is no ascites, all that, and I mean TAH and BSO, omentectomy, pelvic node dissection, multiple peritoneal biopsy, mucinous means appendectomy. Deepti, would you like to add anything?
Ma'am, here only the earlier was the thing that these random peritoneal biopsies was the recommendation. No more we recommend for that. If you have to take peritoneum, we do pelvic peritonectomy. No, there is nothing in the peritoneal random biopsy. So rest all is for the primary early stage ovarian is good, ma'am. This is the thing. Only this
early stage only.
Yeah. So multiple peritoneal biopsies are no more done, ma'am.
Okay. Okay.
Yeah. Yeah, ma'am.
Okay, so is there a need for frozen section? That she already said that she showed the instrument too. Okay, so that will have an impact on the extent of surgery and outcome. But sometimes we can miss, especially this borderline ovarian, it might be difficult to identify. Deepti also showed about HIPEC in ovarian cancer. In a lot of corporate hospitals, this is being done, and so it really seems to be very effective, and especially when used during an interval procedure or in the recurrence setting. But I mean, they feel that more trials are needed, but in many corporate hospitals, this is the norm, because they have seen that it is much better, outcome is much better, and side effect profile is well tolerated. Okay.
One thing I'll add here. So in primary cytoreduction, there is no evidence of HIPEC, but after chemotherapy, there's a randomized control trial. So we have evidence. In this setting, we don't have evidence, ma'am.
Yeah, that is what I said. Interval procedure. Interval procedure means you give a chemo earlier, then after that you take up for surgery, or in the recurrent setting. That is very, very important. Okay. Now, 23-year-old nulliparous woman comes with an adnexal mass 11 into 11 centimeters. How will you proceed? See, these are the patients whom we have lots of dilemma. So how do we proceed? Physicians can take up.
So we will obviously initially after examination, we will go for an ultrasound, and most commonly, and of course, tumor markers. And most commonly for a 21-year-old will be the alpha-fetoprotein and beta-HCG as well as CA-125. And hello?
Yeah. Please continue.
Okay, here. Okay. So after checking what is the, we will have to take counsel her for removal of a cystectomy, depending on what we have found in the ultrasound. And
so it's
like
not
you said,
only ultrasound, isn't it? We will
the ORADs of more than 10 centimeters, right? So when we come to that, and then the number of so based on that, we can decide whether
it has to be pure laparotomy.
Laparoscopy
what
or
is the role for fertility preserving surgery? Deepti, will you do for fertility preserving surgery for this woman? She's nulliparous.
Yeah, ma'am. So before that, so two things actually we were discussing about the initial imaging. One thing I forgot, in this case, there's probably no doubt, but the MRI is also very good investigation to just delineate the type of thing.
Yeah.
We have to do the markers.
True,
Yeah, so we have to do the markers. In that, we should include all germ cell tumor markers, which you have written here. So we have to do beta-HCG, AFP, LDH along with CA-125, CA-19.9, and CA. And then we have to take her for the, and definitely she's a candidate for the fertility preservant. And in this case, if it is a frozen turn out to be benign, we can just leave behind. We need not to touch anything. Only we have to take cytology. You can do omentectomy because it is not harmful, and lymph node just inspection is also enough for these ladies.
Yeah.
And the other opposite normal ovary, no biopsy should be done from that ovary. The earlier the thing was that we should take a biopsy from other ovary, that is no more indicated.
Yeah. So it's very, very important that nulliparous, we have to do other tumor markers too, because of the types of tumors which can occur in such young people. And we have to consider fertility preserving surgery as much as possible. Okay. So what are the risk factors for ovarian cancer?
Borderline. In borderline cases, do we go for chemotherapy?
No, ma'am.
No, borderline, we just do a staging laparotomy. Then, but one thing, once the thing is finished, family is finished, she has to undergo a definitive procedure, isn't it, Deepti?
Yeah, ma'am. So this is the recommendation. The recommendation is also changing, but that's good to go ahead with the completion surgery when she has completed the family.
Yeah. So what are the risk factors for ovarian cancer? So just like breast, BRCA1, BRCA2.
That's true.
Family history of
early
tube.
Early menarche.
Endometriosis.
Infertility.
Yeah. So we should keep on insisting about breastfeeding. Simple, cost-effective measure, which really helps both the mother as well as the baby. Breast cancer decreased, ovarian cancer decreased. So that is very, very important. And baby also becomes very clever, okay, and healthy. So all these things are very important.
OC pills also help to prevent, but they actually increase OC pills.
Yeah, OC pills also prevent, because
ovarian, but they increase the risk in breast cancer, unfortunately.
Okay, how to prevent ovarian cancer? We do not have as Suganya nicely put it across, we do not have a proper screening test as for breast. Okay, and ovarian cancer is diagnosed late too. So how do we really prevent ovarian cancer? This is the article which talks about physical exercise, avoiding being overweight, avoiding smoking, risk reducing salpingo-oophorectomy, that is salpingectomy. So whenever we do salpingectomy, we have to do a oophorectomy. What I'm saying is when we retain ovaries, when we are doing sterilization, it is best to remove the tubes.
Very important point, ma'am. Correctly you told, because the origin of ovarian cancer is most of the time from salpinx, not from the very beautiful and important point. Salpingectomy is a must for the prevention.
Yeah, we should always remember about this. It takes about 5 more minutes and patience. But I think we should take it upon ourselves to do it. Okay. So
I believe it's the last, the lateral, the fimbrial edge, the last 1/3 is what is the most common. So even removal of that should be enough, rather than a total salpingectomy. Like if you're doing it vaginally and you're not able to access.
No, then we might have vaginally we do less. Then also with vaginal hysterectomy, we can really hook it out to a certain extent.
Yeah, to a certain extent.
Ideally, to do a risk reducing, that we should always remember. So breast cancer is the foremost cancer in Indian women. Breast lumps can occur at all ages. 90% breast diseases are benign. Triple assessment is mandatory. BIRAS helps in diagnosis and management. Nipple discharge needs evaluation. And we should always remember when there is some skin lesions also, just plain skin lesions, we should not just apply topical ointment, but evaluate, find out whether there is a mass underneath. Lactation abscess treated by aspiration. Risk assessment and screening for breast cancer, mandatory for all women, more so with family history. Adnexal mass can occur at all ages, even at the fetus. It needs meticulous history taking, clinical examination, and what as physicians we should insist is on our radiology colleagues is evaluation with iota or better still ORAS, and then of course tumor markers. Comprehensive surgery should be done by a competent surgeon, and family history of cancers matter in management. And we know that there is no effective screening tool, but then we have certain things like risk reducing salpingectomy. So we should remember all that. So I once again thank Professor Sampath Kumari for having given me an opportunity to moderate this panel. I thank all my panelists for their inputs, and for Deepti also, who chipped in and gave her valuable suggestions. Thank you very much.
Thank you.
Thank you, ma'am. It was wonderful.
Thank you very much.
Thank you.
Thank you, madam.
Thanks a lot, Sampath Kumari
Thank you,
ma'am,
ma'am.
as
Sampath
well
ma'am.
as
Thank you, ma'am.
Shakun.
Sampath ma'am.
Thank you.
ma'am.
Thank you, Vimla. Thank you.
And Dr. Vijay. And Dr. Vijay Lakshmi also for.
Anyway, thank you.
Thank you. Thank you.
Thank you. Thank you.
Wonderful panel discussion. Very informative.
Sajiti,
Sampath?
can you put the question?
Yes, ma'am. Third question.
This is for again for the delegates. 43-year-old woman with complex cyst in breast needs aspiration, FNAC, core needle biopsy, and excision.
Daddy. Last 10 seconds.
Sakiti, can you put the results after vote of thanks?
Yes, ma'am.
All three you put it.
Yes, ma'am. Time up.
Thank you. So now we come to the end of the CME. I think Dr. Vijayalakshmi Jnanashekaran is not there, so I will give the vote of thanks. First of all, I thank Dr. Shantamani Madam for accepting to be the chief guest, and Dr. Vijayalakshmi Kandasamy and Dr. Nidhi Sharma always accepting to be the chairperson and judge for the Yuvas talking. And I thank the Sukanya and Enbapriya for the wonderful talk. The screening ovarian cancer and the screening of the CA breast. And we had the wonderful talk by the recent advance in ovary and breast by Dr. Deepthi. And she is in a Namakkal, Tangam Hospital. But they are doing the wonderful work. And I thank Dr. Chandra and Dr. Mallika for chairing the session. And finally, I gave Shanti Madam only three days for moderating the panel. In spite of that, she has done a wonderful panel with the good cases. And I thank the moderator, Dr. Shanti Gunasingh, and the panelists again within 3 days, Dr. Vimala, Dr. Swati, Dr. Tamil Kodai, Dr. Pungodai, Dr. Anita, and Dr. Prabha for the good interactions with the panel. And finally, I thank our MOC, Dr. Radhika. And again, I thank Deepthi for involving herself in the panel also and giving her input. And our president, TNFOG president, Dr. Revati Madam, allowing us me to do all the programs whichever we decide. And I thank Dr. Shahiti, the Shield Pharma for the link and the full cooperations, and the Sripriya, our clerical person, for making the communications. So once again, I thank everyone if I have left anyone. And finally, I should not forget to thank our delegates. Today we had 198 delegates registered for this CME. It was really wonderful CME, and I think it will be useful for all PGs, consultant and senior. Okay, thank you. Dr. Sahiti, can you put the
Yes, ma'am.
results?
Results are out.
The first question, Dr. Soumya Ravi from Trichy, and second CA ovary, Dr. Lavanya Kumarasamy from Chennai, and the coronary biopsy, Dr. Sindhura from Chennai. I think this time two prices to Chennai and one to Trichy. First, we should thank Anita joining from Kanjipuram. Yes. Revati Madam, anything to be Shanti Madam, Revati Madam, Deepthi?
Thank you, Sampath.
Only big thank you, ma'am. And the
Thank
great
you.
discussion.
Thank you,
I really
Dr.
enjoyed.
Sampath,
Thank you, ma'am.
for giving importance to our Namakkal people, Dr. Mallika and Dr. Deepthi. They are doing excellent work. And thank you, Dr. Revati and Sampath, for the opportunity given to us. And also, Radhika.
Thank you, ma'am.
Yeah.
In National Forum, we should introduce them in one forum. I am waiting for an opportunity.